aligned ourselves to the WHO global strategy, which is to reduce physical inactivity by 10% worldwide. So we believe that this complete program, which is being carried out, will bring efforts to reduce or to contain the mortality rate caused by NCD.
We are able to assemble here with a bunch of scientists, medical specialists and so forth. And we have a lot of medical doctors this year round. And I have 35 brains from 35 nations, 65 speakers in total. So basically, this is something that we hope that we can impart to all attendants here, that you can go home with some knowledge about exercise.
More to mention, Dr. Sri Jessie Lai had also announced a collaboration effort with the Ministry of Health by setting up its first exercise medicine clinic to promote and introduce exercise medicine in our country. Through this conference, medical experts from various fields and experiences shared their respective exercise medicine-related research reports and further discussed with the experts who were present. This 3-day conference captured more than 60 topics related to exercise medicine.
Not so many people know about aviation medicine, but it is very important in military side. They are working in a very abnormal environment. They are very normal, but they are working in abnormal environment. That's where we are.
I'm here today to talk about type 2 diabetes and specifically how exercise can improve insulin sensitivity. And we know that type 2 diabetes is a disease that stems from being insulin resistant.
I'm basically an orthopedic surgeon and I do a lot of surgeries and a lot of operations. However, the exercise medicine is also important in our everyday practice, and I can get a lot of impression, a lot of new information.
It's a really great conference. Congratulations. I present the natural lifting with exercise of elastic fibers.
I never thought they were related together, and end up we find out the exercise is for the healthy life. And breastfeeding is for the healthy life. So we are the same track. So when I come into the conference, to be honest, I think I belong here.
When there are exercises, our body responds well by producing different hormones.
So that's a mindset change. So that's why I'm saying I'm working with the mind, because we work top to bottom, right? So if you can make a change in the head, then the entire body will change.
For the future, the exercise medicine will be the new way to treat the patients.
Apart from academic research reports, presentations and exchange sessions, during the intervals the organizer planned exercise activities for all participants with the aim to get everyone to experience the integration of exercise into their lifestyles. In conjunction with the theme of exercise medicine, the organizer had also invited Malaysia's renowned artist Fatia Latif to present the theme song of this conference, Just Keep Moving. In the closing night of the Exercise Medicine Conference, college students from Asia College of Exercise and Sports Medicine performed Malaysia's cultural dance to the guests from all over the world. In the night, the conference also announced its next World Conference on Exercise Medicine to be held from 16th to 18th of August 2019 at the Palace of the Golden Horse in Kuala Lumpur, Malaysia. It is the organizers' hopes that in the coming days, the World Conference on Exercise Medicine can continue its efforts to promote exercise medicine to benefit all folks in the world.
Welcome to the Truly Asia Malaysia, and welcome to the 3rd World Conference on Exercise.
Our World Conference is to save the world. We are all here to save the world. This is our ultimate. I want to stress that the physical fitness is more important than the body weight itself.
When we're designing exercise training programs, we need to consider the basics, the principles of training.
Very much need to be aware, if we do studies in this setting, about does it impact operability and resectability.
Prescribing exercise is not like a cookbook.
We need to consider about the concept, the causative factors, why he or she have this chronic low BP.
We are contributing our parts and have aligned ourselves to the WHO global strategy, which is to reduce physical inactivity by 10% worldwide.
This is something that we hope that we can impart to all attendants here.
Penuaan adalah proses semula jadi. Akan tetapi, penuaan haruslah dihadapi secara sihat dan tidak menjadi beban kepada orang lain. Menjadi seorang warga emas yang sihat tidak semestinya bebas daripada sebarang penyakit. Warga emas yang sihat sepatutnya dilihat sebagai seorang yang mempunyai kualiti hidup yang baik. Seseorang haruslah mampu berdikari dan mampu untuk bergerak dengan sendiri. Untuk mencapai kualiti hidup seperti berikut, kita seharusnya bersenam dengan kerap di samping menjaga pemakanan. Saya adalah seorang yang kerap bersenam dan nasihat saya kepada yang sedang menuju ke arah status warga emas adalah untuk memastikan senaman itu dijadikan sebahagian daripada rutin seharian untuk mengelakkan pengecutan otot dan mengekalkan stamina.
Tun, berapa kali Tun bersenam dalam satu minggu?
Saya kalau boleh itu tiap-tiap hari lah. Tapi tak ada masa, kadang-kadang 2 hari sekali, 3 hari sekali.
Tun, bagaimana Tun cari masa untuk senam apabila Tun tidak berada di rumah ataupun masa Tun cari?
Masa kita berjalan ke tempat lain, sukar untuk kita teruskan rutin kita. Tetapi ada cara-cara lain. Umpamanya kalau kita boleh berjalan, kita berjalan sedikit. Dalam rumah pun boleh. Dalam rumah pun saya biasa berjalan sehingga 6 round di atas beranda. Itu mencukupi bagi saya.
Adakah Tun melakukan latihan berbadan?
Weight ada. Saya guna dumbbell. Dumbbell angkat sikit. Tapi weight yang berat tidaklah.
Pengerang mempunyai hampir 100,000 penduduk dan 90% daripada mereka adalah masyarakat Felda dan kampung tradisi. Kebanyakan mereka adalah tergolong daripada warga tua berumur melebihi 50 tahun. Pada tahun 2020, dianggarkan bahawa penduduk Malaysia yang berumur lebih dari 65 tahun adalah sebanyak 7%. Malaysia ketika ini menghadapi prospek penuaan penduduk dan data statistik terbaru meramalkan ini akan berlaku seawal tahun 2030. Kita perlu bersiap sedia untuk memenuhi tuntutan dan cabaran penduduk kita yang semakin tua. Kebanyakan golongan warga tua ini mempunyai tahap kesihatan yang kurang baik serta ada di kalangan mereka yang menghidapi pelbagai penyakit tidak berjangkit NCD seperti kolesterol tinggi, kencing manis, darah tinggi, sakit jantung dan berat badan berlebihan. Ada juga yang menghidapi penyakit kronik seperti strok dan lumpuh. Justru, untuk mengatasi masalah yang ada seperti kurangnya pengasuh profesional, perawatan yang berpatutan dan perumahan yang mesra orang tua, terutama di kawasan luar bandar, satu program latihan perawatan kesihatan rumah yang juga dikenali sebagai program penuaan aktif telah dijalankan untuk melatih ahli keluarga atau sukarelawan kaedah yang tepat untuk menolong warga tua. Pusat penuaan aktif dengan kerjasama Rakan Aktif Parlimen Pengerang yang dipengerusikan oleh YB Datuk Sri Azalina Osman Said adalah sebuah pusat latihan minda dan tubuh difokuskan pada golongan warga tua yang berusia 60 tahun ke atas untuk mempertingkatkan kualiti hidup mereka. Pusat penuaan aktif ini adalah sebahagian daripada inisiatif aktiviti komuniti Rakan Aktif Parlimen Pengerang. Pusat penuaan aktif menggunakan peralatan senaman kekuatan otot isokinetik dan ianya adalah kaedah latihan otot yang paling selamat, berkesan dan paling menyerupai pergerakan otot manusia dalam penyelidikan klinikal di seluruh dunia. Peralatan ini dapat menetapkan kelajuan dan perubahan rintangan bersama dengan jumlah daya yang diaplikasikan oleh pengguna. Ini adalah peralatan senaman terbaik untuk warga tua. Selain itu, peralatan Dr. Fit Cardio dilengkapi dengan perisian Dr. Fit Treadmill Automatic pertama di dunia yang beroperasi mengikut kesihatan jantung anda. Ia membimbing anda melalui sesi pemanasan badan, dos dan intensiti serta sesi penyejukan badan secara sistematik tanpa rasa tidak selesa dengan formula heart rate return. Pusat penuaan aktif, kekal aktif untuk kehidupan yang berkualiti.
They expect the hospital to be a place where
you can't ask the urologist to manage breast cancer.
I'm actually lost of words because over the 3 days it was like today it has been another historical day. Thank you.
The second World Conference on Exercise Medicine was held for 3 consecutive days, from 24th to 26th September 2018, situated at the World Heritage Site in Malaysia, Malacca. Coming to its second year, the World Conference on Exercise Medicine had received overwhelming participation. In addition to receiving support from the European Medical Association, Malaysia's Ministry of Health, the Government of Malacca and respective corporate
Pick up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. Here is where we stand. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Oh, let your steps pick the way for the future. 'Cause you're alive, inspiring others. Don't you lose your hopes due to hurt and loneliness. 'Cause there's always another way. And all the nation together as one, fighting for a brighter future. Gathering all our brothers in arms, here we will stand tall. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Just keep moving. Just keep moving. Just keep moving. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is yours now, so just keep moving. Oh, yeah. Pick up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. Here is where we stand. So just keep moving. perhaps pave the way for the future. 'Cause you're alive, inspiring others. Don't you lose your hopes due to hurt and loneliness. 'Cause there's always another way. And all the nation together as one, fighting for a brighter future. Gathering all our brothers in arms, here we will stand tall. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Just keep moving. Just keep moving. Just keep moving. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Yeah. Pick up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. Here is where we stand.
Good afternoon, everybody, and good morning to the rest of the world, and welcome back to our 5th day, which is also the last day for our scientific program, which is the 5th World Conference on Exercise Medicine. I would like to wish Professor Henry Dow. I forgot to do it yesterday. It was a birthday. And how young are you today? Anyway,
63.
63. Wow, that's awesome. You look so much younger than 63. That's the way.
Thanks for
All
the
right.
meeting.
Yeah, you're most welcome. Okay. Today we have some very exciting program. All right. I think there's a new field that we have added this year. We will begin with shortly after this, Dr. Bradley Elliott from the United Kingdom. There he is. All right. He will be presenting a paper on exercise physiology as a tool to probe the limits of human longevity. I think this is a very interesting paper. Right. After him, then we have a very reputable urologist from Malaysia, Professor Dr. Bobby Goh. He will be talking about exercise. Is it more than a healthy heart? Then we have my old friend, my dear old friend, Dr. Sean Galloway from Canada. He is specialized in psychologist and working with children, motivating children to be physically educated. I think literacy in physical activity is one of the main subjects that we have discussed so far. And this is something new that this year that we have included from Dr. Siva Neswaran from Malaysia. He is the president of the Malaysian Lifestyle Medicine. All right, so he is going to give us a very interesting paper. And then we have an interesting expert. I hope they're going to play a song called Car Wash today. I don't know why. Okay, without any further delay, I would like to introduce Dr. Bradley Elliott from the United Kingdom. He has a pre-recorded version of his paper, and then Dr. Elliott will be on standby live to answer your questions. All right, Dr. Elliott, you can proceed.
Hi there. My name is Dr. Brad Elliott. I'm a senior lecturer in physiology at the University of Westminster in London, UK, where I also founded and lead the Translational Physiology Research Group. It's my great pleasure to be here talking to you today about using exercise physiology as a tool to probe the limits of human longevity. And it's also I'd like to give thanks to the conference organizers at the World Congress of Exercise Medicine for inviting me here to speak. Human beings follow a very predictable pathway in terms of birth, growth, and aging. And it's almost without doubt that the vast majority of us, from about 30 to 35 years of age, will show a decrement in physiological performance of any given system. So we can graph this, like I've done here, where if we consider time on an x-axis and any measure you want on the y-axis of physiological function, it can be things like grip strength, muscular strength, bone density, but it can be eyesight, wound healing, immunological function, or all sorts of different cognitive measures. We show a very predictable path from about 30 to 35 years of age. We decrease as we get older. This is a rather complex physiological set of mechanisms, but collectively we term this aging. We also know that human beings show great variability in how they age. So for example, if we intervene in people in early adulthood, in the 20s to 30s, and they become, for example, say highly active with a lifestyle change, then over the course of their remainder of their life, they're much more likely to age better, maintaining physiological functions into older age. And this is obviously advantageous. This is what we might call, say, healthy aging. But we know as well that the time of this intervention doesn't matter in terms of physiological systems. So for example, if we intervene in someone's 20s or 30s, we might see a good outcome. But we can intervene with exercise physiology in people in their 80s, 90s, or even recent publications in their hundreds and 100 plus years of age, introducing stimuli like resistance exercise to people, obviously graded for relative intensity, but at any point in the life course with aging, intervening with exercise gives positive outcomes. And we can look at this with an example like we have here. This shows grip strength for 50,000 people among males and females. And we see the exact same pattern I'm drawing for you below, where we have time on the x-axis, age, and on the y-axis, we have the measure of, in this case, grip strength as the function we're talking about. And we see this very predictable pattern. We see people increasing, plateauing, and then from about 30, 35 years of age, decreasing over time. That's cool. That makes sense. But we also see something else I want to focus on today. It's not a tight range. It's not deterministic. Human beings show incredible variability with age. And this draws out the question, why? Why do we vary so much? And you can go down incredibly deep pathways here when we start thinking about this. Is lifestyle to blame? Is there genetic factors involved? What is it exactly? And one of the ways we've tried to understand aging, both in any species and in humans, both in any species, and including humans, is thinking about aging from 2 points of view, primary aging and secondary aging. The difference being primary aging is a thing that will change as a function of time, and secondary aging being a physiological process that's influenced by lifestyle factors. So, for example, with disuse or inactivity, people's cardiovascular systems decrease in function, people's muscles are not as strong, bone density goes down, things we're quite familiar with. And some would argue those are secondary aging characteristics. They may or may not even be aging at all. They might just be inactivity. So the question becomes, do these secondary aging factors explain some or much of this variation we see in a variable like grip strength? And if so, can we probe and study this? And one way around this question must be to try and recruit highly active older individuals or masters athletes. It's kind of the point of the talk I want to give you today. And this is important because as we age, we are much more likely to be unwell. We show an increasing risk of cancers, of metabolic disorders, of cardiovascular disease, of cognitive dysfunctions, of horrible neurodegenerative diseases like Alzheimer's, like Parkinson's. And all of this complexity leads to increasing risk of death. And that the risk of these diseases, the risk of death itself, as I've graphed here, isn't increasing at a linear rate. It increases exponentially. So, for example, among a 30-year-old, mid-30s, the chance of death in any given year from any cause is roughly 1 in 1,000, which isn't bad odds. But as people get older, the likelihood of death itself increases exponentially. And I could have also graphed likelihood of diseases here as well, and the same curve occurs. And if I continue the graph upwards into the 90s and hundreds, we see the exact same thing. There's some hint in the data that after 100, 110 in the super ages, this risk might start to plateau, which is interesting. But it seems to be up until about 100, we see an exponential increase in the risk of death as you get older. So this is a talk about exercise. And it might surprise none of us to say this, but to be clear, exercise and indeed just simple physical activity is good for you. Thanks for that. Thanks for coming to the talk. I'm glad you got the point. But we know this from a number of different ways. So if we look at very large populations like we have here, we see that both duration of physical activity and intensity of physical activity both seem to increase life expectancy. No, excuse me, increase longevity. This is data on pure mortality, so the risk of death. And again, we see people as they get older are more likely to die, but the more active they are, the healthier they stay for longer. And in this case as well, the less likely they are to actually die. And so we know exercise is good for you. We know simple physical activity is good for you. On the top here, we have a cross-section of the thighs of a 40-year-old athlete. So we see very thick, dense muscle. We see very thin subcutaneous fat. We see good bone density. We see high quality muscle as well. So we have a really healthy, good picture. Below that, we see a very classical MRI, again of the thighs, of a 70-year-old inactive man, of what is very stereotypical in Western society of an older gentleman, an older 70-year-old. We see very thick subcutaneous fat. We see very much smaller muscles, but as well as that, the muscle mass itself isn't just decreased, but the quality of the muscle is decreased, with intramuscular fat and fibrosis occurring. So we see less dense muscle. The bones are frailer. The cortex of the femur is much thinner. We see all these characteristics of musculoskeletal atrophy. We see a very negative picture. We see the effects of 30 years of aging. And of course, if you've seen this before, and many people have in this field, a cliche of this talk, but I have to show this picture. At the bottom here is a 70-year-old, but a masters athlete, a person who's been highly active over the course of their life. And what we see is an MRI scan that is more young-like. It shows greater muscle density, it shows increased bone density, it shows less fat, it shows all those things we expect from a younger person. And so for this reason, and not just this picture, but this idea of masters athletes maybe delaying or offsetting some of their physiological effects of age, secondary, maybe primary, maybe not, we have our model. We have a model here, a gold standard, which we can compare different types of aging to, and maybe even compare aging processes to. We have a positive control we can use. So if we have a positive control of aging, what factors do we study? What processes do we examine? How do we then challenge this idea of aging? Well, in the aging field, again, another cliche is the hallmarks of aging. This idea that to understand physiology of aging, to understand how aging happens, we should consider 9 hallmarks of aging. Classic paper, very much worth a read. Got a citation here if you've not come across it before. Breaking down aging into things that we're familiar with. So, for example, intracellular communication, endocrine, genomic instability, telomeres, but some we're not so familiar with perhaps, like mitochondrial functionality, a very new field of senescence, and potentially even now senolytic drugs, which is very exciting. And so what we have here is a model we can probe. And if we have a model, these are the 9 variables that are involved in aging, and we have a positive control, which is our masters athletes as a model of highly successful aging, we can now probe each of these individual factors and say, well, does each one stand up? So if we examine, for example, a group of older and active individuals next to older masters athletes, does one of these variables look the same between groups? And thus it's a factor of chronological age, or do the masters athletes look, physiologically speaking, better on any given factor? And now we have a biological marker of aging. We can stress test the hallmarks of aging using masters athletes as a model to do so. So I won't go through every individual factor on the hallmarks of aging, because I am aware that I have a time limit. I don't want to talk too long. A large amount of my work and career has been studying a signaling hormone called myostatin, a signaling peptide, myostatin, produced by muscle, secreted around the body. It regulates muscle mass. It has another very similar peptide called GDF11, growth and differentiation factor number 11. And GDF11 is an interesting one. We're not really sure what's going on, but it has been postulated to be a good biomarker of aging, in that it goes down as people age. It seems to reflect function in a number of different ways. And as we showed on this top graph here, if you examine lifelong exercises, they tend to have higher levels of GDF11, more young-like levels, than do lifelong inactive individuals. We then put them through both groups through a high-intensity training protocol for 6 weeks, and showed that GDF11 didn't change pre to post 6 weeks training in both the inactive group and also in the highly trained lifelong exercises. And that was really interesting. So it suggests that lifelong exercise was enough to maybe offset this, or that short-term interventions weren't enough. Or alternatively, it might be that the highly trained individuals, the lifelong exercises, were more active because they were predisposed, because this was potentially higher. You have to be aware of the causality argument. We weren't sure which way around this was. One of the hallmarks of aging that most people are familiar with, and even in public engagement in public science these days, is telomeres, chromosomal caps that are involved in DNA replication. There's been a lot of studies showing that telomeres are longer in highly trained masters athletes than they are in, say, inactive controls. And there's even been a few studies that show with short-term training interventions over months, 3 to 6 months, we can start to lengthen telomeres again. And this has always been held up as a good example of a biomarker of aging that is potentially secondary, that responds well to lifestyle interventions. However, there's been a very recent meta-analysis published, which was very critical of the field and held the data to very high standards, and found a lot of publications on telomere lengths in exercise and active populations weren't high quality papers and had somewhat risk of bias. While it did suggest masters athletes may have longer telomeres, it also suggested that the evidence for telomere lengthening with short-term exercise interventions was poor and needed to be regarded cautiously for now. So an interesting one that might need a bit more attention. Genomic instability is something we see with aging. So the idea that nuclear packages within cells can become unstable, and even the genome itself can start to unravel, thereby leading to cellular dysfunction and cell death. What I've got here is an example that a good friend and colleague of mine, Dr. Manisa Usman, produced using buccal cells from the mouth. So taking cheek swabs from people, staining them for nuclei, staining the background cells, and then looking for nuclear malformations. And so you can see here some of the really cool examples of nuclear budding, with the nuclei giving off small buds. They're splitting, but not in a normal mitotic way, or they're showing interesting malformations suggestive of genomic instability. And using morbid obesity among children as a model of accelerated aging due to the metabolic the perturbance that these children suffer, Dr. Usman showed that these genomic instability markers were elevated in overweight and metabolically unhealthy individuals relative to healthy controls, and indeed that they correlated with body mass in overweight population, suggesting that this perturbation was bad for genomes and might be a model of accelerated aging, which is really interesting findings. When it comes to exercise interventions and exercise training, there has been a bit of work in this field, but not a huge amount. So for example, one large study, I think from the Vienna Aging Group, over about 6 months, I believe it was, looked at genomic instability markers similar to those ones that our institution looked at here, and showed no difference pre to post 6 months training in an older population of women. And so they thought that was interesting, but then they had a closer look at the data, and they noticed that they had a large number of dropouts from the exercise intervention in older 80-year-old women over 6 months. And then what they noticed was at baseline, the participants that dropped out were much more likely to have elevated markers of genomic instability relative to the ones who completed it, suggesting that those that completed it might be predisposed potentially because they're in a better place, physiologically speaking, at the start of the trial. Again, an example of survivorship bias. One of the most exciting markers in the hallmarks of aging, one of the most likely ones to be used as medical treatment in the near future of aging as a process, has to be senescence, the idea of targeting senescent cells, and specifically immunosenescence. So this failure of the immune system with aging, leading to an increased risk of immunocompromise with aging, death from common infectious diseases like the flu, or as we're seeing at the moment with an older population, with infections like COVID-19. And so, for example, immunosenescence probably leads to immunological aging, like I've got on the bar graph shown here, massively elevated IL-6 as a marker of inflammation in an inactive older population, but in a highly trained masters athlete population, we see this basal IL-6 back down again, suggesting that immunosenescence is offset by lifelong exercise. And we see I've got a few markers here from B cells. We can also look at T cells in different states. In the reference from Dougal out of Janet Lord's group in Birmingham, fantastic data set, really interesting analysis showing immunosenescence offset by lifelong activity. We did some similar work in this area just to show our own papers a little bit. Sorry about that. And in a similar manner to this paper, showed that, say, IL-6 wasn't elevated at all in masters athletes relative to a highly active younger population, confirming their findings, but also showing a bunch of other markers as well. One of the variables I've mentioned a few times, and something we have to be aware of in this field, a common critique of using something like masters athletes as a positive control, is we have to be aware of the risk of survivorship bias. The population we're studying in highly active older athletes is highly trained and healthy and interesting physiologically, but we're studying them because they've survived, because they are alive. And those that haven't survived that long, we're not studying. And so we have to be very careful of the fact that we're studying a unique population, but potentially a self-selecting population. So we always need to consider inactive controls and maybe even a negative control like frail, highly inactive, or pathologically unwell, sarcopenic, or frail older populations. So we have a spectrum of aging to compare it to. And if we interject, say, a short-term exercise intervention, it's useful to have inactive and also a master's group, both changing. And so we can see, is the effect short-term or is it long-term, or what's going on? So we have to be wary of survivorship bias in our results in this field. And another thing that's worth being aware of, and as an exercise physiologist, I'm very aware during this talk that it's a mistake that I have made very openly, is we talk about masters athletes as a group, where of course, say lifelong cyclists versus power sports, sprint sports, or lifters, like Olympic lifting, for example, those are 4 groups of masters athletes, but 4 incredibly different stimuli from the physiologist's point of view. So when we lump masters athletes into a cohort, that would be as ridiculous as lumping all younger athletes into a cohort and saying that we expect them to be physiologically the same. Where a life of strength training is probably incredibly different as a stimulus as a lifelong aerobic training. And even in the field of aerobic training, if we consider, say, cyclists who don't have repeated gravitational loading of running versus runners, we're going to see differences in bone signaling, differences in muscle signaling, and probably a different outcome. And so there's work to be done comparing different groups of masters athletes and how they age. And maybe we can use that to stress test, say, the hallmarks of aging some more. So that's the model that we're using. That's what I want to present to you as an example. I do believe masters athletes presents an interesting positive control that we can use as a key model to stress test, say, the hallmarks of aging model. They're probably not the only positive control we can use. We can consider, say, intermittent fasting or caloric restriction models, which also show longevity benefits and health benefits, but they are a model that we can use in this field. We can use this field and use masters athletes to identify what is primary and what is a secondary aging factor. Are the aging factors we're seeing in inactive older individuals just because they're inactive, or is it because they're older? So identifying what is primary, the effect of time itself, and what is secondary, the effect of lifestyle factors, needs to be teased out. Masters athletes can help us with this. If I had to say, and it would be challenging to pin this down exactly in my mind, that several of these factors in the hallmarks of aging are probably both primary and secondary. And separating out primary and secondary effects here becomes incredibly difficult. But if it was easy, everyone would do it. I guess this is science. But by identifying which is a primary factor and which is a secondary factor, we can identify which factors of aging we target through lifestyle interventions and which we can start to target with pharmacological targets, like, for example, the current work in senolytics moving towards human trials. And I'd also like to thank my research group, those people that have done the vast majority of the work that I've published in the last 5 years, my wonderful PhD students, Bonnie Kirigato, Isabella Cooper, some of the other researchers that have worked for me, and also some of the granting bodies and societies that have supported my work, including the Quinton Hogg Charitable Trust, the Robert Mitchell Society, and the Society of Endocrinology, who supported some of my very early work in my career. Thank you.
Good. Congratulations to you, Dr. Brandy. You have a good team. And I think your paper is getting, your paper is going to get a lot of attention. A lot of people are aging. The world is getting old. And there's going to be a lot of, yeah, I think you're still very young. All right. Do we have any questions from the floor?
While we have a look at that, I'm going to just apologize for doing a pre-recorded talk and still going over my time limit.
It's okay.
It was 21 minutes, even with some very unsubtle edits that I put in there to try and remove a little bit of my talking too much.
Okay, if there's no question, I have one question for you. It's in relation to the aging factor, right? Is the physical activities that you have mentioned that have the extension of the telomere, is this one of the key components to look at if we talk about what we call reversing the aging or slowing down the aging process?
I think there's multiple parts of that question that I could pick apart and spend way too much time answering. The second half of it, slowing down the aging effects that we consider aging, that might just be inactivity. That's what we're talking about when we talk about this primary or the secondary aspect of aging. Is that via a telomere lengthening effect, as we see like either reduced rate of shortening of telomeres or even restoring length of telomeres, like some exercise studies have shown? Maybe 6 months ago, I would have said yes. Maybe now I'm thinking no, after the recent meta-analysis I mentioned in this talk, that was very, very critical of this idea. But it picked up on a common problem we have in exercise physiology, and that we tend to do smaller, underpowered studies that makes it very difficult to critically evaluate the data that's coming out of them. And it does suffer that issue of trust relative to other randomized placebo-controlled double-blinded trials. But that, of course, raises the next question: is how do you double-blind placebo-controlled exercise? Of course, you can't, right?
Yes, of course.
So it's one of those really rubbish scientific answers. So I'm going to say I don't know, but I am leaning more towards no than I was until quite recently.
Yeah, I think this is a field. No doubt, there's a lot of paper, but there's a lot of conclusive things that you can look at, which is a very interesting open field.
I think the key point there is absolutely that exercise is good for you. Of course it is. Like, we're all agreeing on this, right? The exact mechanisms of how, we're not sure, and that's really interesting because that gives us as scientists
It's such a vast scope, and we do not know where to zero in.
Exactly.
Okay, all right. I think you have a question. What is the current recommendation to improve elderly immunity?
I think maintaining physical activity guidelines is brilliant. So I think we're seeing that. Excuse me. We're seeing that with some of the data. I think it's Janet Lord's group that I mentioned in that talk, where they looked at, say, a masters athlete model where they had young-like immune function. And I can't pick a citation off the top of my head, but I'm pretty sure we see return to improvements in immunological signaling in older populations with basic exercise interventions. So, for example, in the United Kingdom, where at the moment, the current guidelines are at least 30 minutes of low-intensity exercise most days of the week. And that doesn't sound like a lot, but most people don't do that. And one of the ways that we know that improves your health is via improvements in immunosenescence. And so that's improved immunity. And we're seeing that so horribly at the moment, aren't we? The tagline of this conference this year is living with COVID. And we've been talking for so many years about non-communicable diseases and how important exercise interventions are for them. This year, we're living in the shadow of COVID-19 18 months later. But we're also seeing still how important exercise physiology is, because we know it maintains, as your question suggests, immune function. And we are seeing from mortality data that type 2 diabetes, that metabolic syndrome, that obesity are overrepresented in the data. And we know that there's this, or as we suggested in this talk, this is one model we can use as accelerated aging.
Okay, thank you. Any more other questions? All right, if there is no more other questions, then thank you very much, Dr. Elliott.
Thank you, Dr. Lee and organizers for inviting me this year.
Thank you. Thank you.
Pleasure.
We hope to see each other very soon in the next conference. Okay. We will proceed on to our next paper. All right. I think everyone here, we are well aware that NCD has been the killer of mankind for the past decades, and WHO has actually came up with a lot of SDG, and we are still working on that. So we are looking into the aspect of exercising correctly with the right dosage, so as to combat this NCD and to reduce the mortality rate of it. But on top of this NCD's impact towards mankind, we have over the past 2 years the issue of COVID-19 that sits on together with NCD that kill mankind even more further in numbers. So I think we will have to work a little bit harder on that. All right, the next speaker is from Malaysia, a very reputable urologist, a surgeon from one of the local hospital here. He is Professor Dr. Bobby Gore. He will be delivering a paper, Exercise, It is More Than a Healthy Heart. Right, Professor Gore, please take the floor.
Hello, good day to you. My name is Dr. Goeng Hong. I'm a urologist currently practicing in Malaysia. I want to say thanks for the great opportunity to present a talk in this great event. So the title of my topic is Exercise. It is more than just healthy heart. So usually when it comes to exercise, most of us would associate exercise providing the benefit towards the cardiovascular health. So I think this is something which is quite well known, not just among us in the professional bodies, but also the public. Okay, so I'm also sure that we are aware that the cardiovascular health is closely associated with metabolic syndrome. All right, yeah. So, but I think it should be known, at least by now, that the benefit of exercise is much more than just giving the benefits to the heart and the lung. Okay, and because of this, the benefits which clearly exist in many other disciplines of medicines, and it is hoped that this presentation would highlight what exercise could do to the whole body, and it's much more than just to the heart. Okay, so before I begin, so what is metabolic syndrome? In general, the definition varies from different professional bodies, but in general, it comprises hypertension, also impaired sugar tolerance, cholesterol disease, and obesity. All right, this is the general criteria that exists for someone to be considered having metabolic syndrome. All right, so I'm a urologist, and then but what is urology? In the field of medicine, there are different specialty. All right, so my field is urology. So basically, we deal with disease of the kidney, the bladder, the prostate, the testicles, and fundamentally, my field is about the health of the genital urinary system disease. All right, so therefore, we have to cater to a wide range of disease. Okay, yeah. So what we see usually are diseases such as a stone in the kidneys, or problem with urinations, cancer such as cancer of the kidneys, bladders, and prostates, and then or someone having a hormonal abnormalities such as hypogonadism. So these sort of diseases seems quite remote from the metabolic syndrome, but if you look hard enough, there are potential closely linked associations. All right, so I think because of this reason, I feel the field of urology seems to be one, especially in which that we should look at the metabolic syndrome closely for the benefit of our patients, not just for their cardiovascular health, but also their health in general. Okay, yeah. So there have been a few articles on urology and association with the metabolic syndrome, but there's one paper which describe these two disease, these two the discipline, the urology and the metabolic syndrome, quite extensively. So I just highlight a few of the topics that was discussed in the paper. Okay, it's a paper titled Metabolic Syndrome and Urology Diseases, and it's written by Gawachinsky and the others. So First of all, stone formation. So what is the pathophysiology between stone formation? In general, we usually advise patients to drink sufficient amount of water, all right? But the thing is, it is much more than just water. So based on the advice by a lot of professional body, it always been about having a balanced diet. In that sense, the advice is against taking too much of salt, protein and fat, and also control the body weight as a form of stone formation, against stone formation. This because stone is a disease we tend to recur about 30% in about 5 years. So the slide so demonstrate quite briefly the pathophysiology of stone formation. So the other thing is urinary disturbances. So when someone has problem with urinary flow, they usually have a mixture of symptoms. For example, they have to go to pass urine very frequently. They find it hard to postpone the intention to go to pass urine. They have to get up in the night, pass urine, or when they reach the toilet bowl, they have to spend longer time to pass urine. They have a sense of incompleteness after they pass urine. So these are just the varied symptoms of the urinary disturbances. So even then, it looks like Metabolic syndrome is one sort of risk factor for the development of urinary disturbances. I think one of the things is that with the weight, I suppose should be a pressure in a simple way, a pressure on the bladder, and with the disease in the blood vessels, there is potential ischemia to the pelvic organ, causing this disease to the bladder and the prostate, etc., resulting in a problem with urination. All right. So another thing is a sexual dysfunction. So chiefly among these is a problem with erection. So put it this way, the penis, the artery of the penis is actually much smaller than the artery to the heart and to the leg. All right, and it is known that for somebody to be able to achieve a satisfactory erection is majority the interplay of the nerve and the blood vessels, and it is because of the vitality of the blood vessels that resulting in the satisfactory erection. So when there's problem with erection, one of the chief cause is the endothelial dysfunction, and this is potentially a consequence of Metabolic syndrome. So therefore, it has been postulated when someone having a problem with erection, it probably a sign to say that a potential cardiac event in about 3 to 5 years from now. Okay, another thing is on hypogonadism. Why so? So when someone having a more risk factor of a Metabolic syndrome, such as hypertension, diabetes, and cholesterol, then of course the risk is that more than likely the patient would achieve lower amount of testosterone, and it is known that testosterone provides vitality to the man for the cardiovascular health, for the muscle bulk, the bone health, etc. So therefore when someone is having these risk factors, the risk of having hypogonadism will be as a consequence more likely to occur. Okay, with hypogonadism, a man will experience just like menopause, like mood disturbances, like post-sleep, fatigue, and probably erections. Yeah, so pretty much affecting the quality of life. So another thing is infertility. Yeah, so quite complex form of pathway, but it's just a slide to show you the various way whereby Metabolic syndrome can result in the infertility. Okay, so I think one of the things is because of the weight and also the poor blood flow, causing these rather undesirable end results. So another thing is prostate cancer. This problem has been discussed a few times before in the previous events, but I thought just one slide to emphasize again the potential effect of Metabolic syndrome towards the occurrence of prostate cancer. Okay, so besides urology, there are also quite a number of diseases belonging to other specialties in which the mechanism seems to play a vital role in causing this sort of rather what to put it under cancer disease, which is quite affecting the quality of life. So I just provide you some 3 examples here. The first one is about the gastric reflux. All right, as seen among patients with the Metabolic syndrome, and also with Metabolic syndrome, there's increase of knee osteoarthritis, resulting in pain to the knee and therefore unable to walk much, affecting the quality of life, and also a potential association between Metabolic syndrome and breast cancer. So another thing is sleep disorders. The thing is that sleeping is something that we all, something that well earned after a hard day at work. So it is a very meaningful way of resting, something that we require every day at the end of the day. Okay, and also when someone falls sick, they clearly need to have a restful night so that we can recover for the next day. All right. So the problem is that when someone have sleep disorders, they'll be having how should I put it? They're not able to rest well, and that clearly could affect their daily activity. Okay, so in this regard, Metabolic syndrome clearly has an associations. Okay, yeah. So what are the examples of sleep disorder? It can be insomnia, like poor sleep, or obstructive sleep apnea. Okay, yeah. So what are they? Say, so sleep disorders. This is because when someone has a proper sleep, obviously they can have a good rest, and therefore the next day they can perform better. And also, it's sort of a bi-directional effect on one another. This is because when someone has exercise, the exercise itself could actually promote sleeping in the better quality. So therefore, sleep is vital for us. And how do we get better sleep? So having exercise is a valid way in which we could have a better quality of sleep. So another thing is vitamin D. So what are the benefits of vitamin D? Well, traditionally we mentioned that vitamin D is vital for the health of the bone. Well, the thing is that the benefits are increasingly recognized. Okay, so there are various sources which we could attain the vitamin D, and one of the sources is actually exposure to the sun, something which is rather, put it this way, quite easy and free of charge. Okay, so therefore it's something that we should take the most advantage of. Most of the time when we go for exercise, more than likely it is an outdoor activity. So therefore, with exercise, there's more chance that we are exposed to the sun. Okay, so therefore, so when we go for exercise, we are not getting not just the benefit of exercise, but also getting the vitamin that we need so much. All right, so the increasing evidence is that when someone having an exposure to vitamin D, there is an effect on the urine flow, and on top of that, it seems to have an effect on the immune system also. Well, this is clearly something quite important in the setting of a current pandemic. Okay, so another is immobility. Right, when someone is sick, they tend to rest in bed, or someone who is not well, after surgery, they tend to rest in bed. But routinely, whenever it is possible and when it is safe, we usually encourage patients try to ambulate as early and as much as possible as long as it is safe. Yeah, why so? Because when someone is immobile for too long, the negative effect is quite plenty. For example, problem to the heart, cardiovascular health, and then when they lie down for too long, they'll be at risk of getting pressure sore to the skin, and then when they lie down, they're probably not able to breathe well, causing atelectasis and a pneumonia. And they lie for too long, there's a negative effect towards the bone and the muscle, etc. And also when they don't move much, the stomach and the gastrointestinal function will be affected as well. So that's the purpose why we tend to encourage patients to move early as much as possible. So another thing is, the thing is that if we encourage exercise so much, but what are the side effects, what are the adverse effects of exercise? Well, there are quite a lot. Even in my field alone, there are examples in which someone could get injury from exercise. So what are they? Well, The first thing is trauma. It can either direct or indirect. For example, in terms of direct, it's like a contact or impact. You can get pain, or in the pelvic area, causing a rupture to the bone or rupture to the tendon, or to get sportsman grind because of stress on the muscle and ligaments. And then when someone who run for long distance, like for example, marathon runner with relative empty bladder, having the bladder slapping on against each of the surface, that could cause bleeding. Okay. Another thing is uterine infections. Well, very funny. Why? Because when someone exercise for a prolonged period of time, clearly you'll be having profuse sweating, and then when there's so much of humidity, there's always a risk of urinary tract infection. Okay, and also when a lady they go for a very intense exercise, for example, exercise which has against the gravity with the intensity, there's potential risk causing stress incontinence. Okay, yeah, and the last thing is about stone formation. Why so? Well, this is not really a direct effect. This is because when someone go for exercise, clearly they sweat so much, and therefore they are in a state of dehydration. One thing is about fluid replacement, and then being in that state, there'll be some who prefer to take drinks which is isonic sports drinks, as a form of rehydration. The issue is that these sort of drinks, it sort of have compounds that are the kind of sugars which has the potential transmission into stone. So therefore, there's a risk of stone formation among people who drink this sort of this sort of isotonic drinks. Okay, yeah. So the conclusion is that with the improvement in the healthcare, clearly there'll be increased life expectancy. People could live longer now. Okay, the problem is that if our approach is not universal, they could have extended the lifespan, but the other part of the health is not properly being taken care of. So yes, they may have extended lifespan, but they still suffer from various other diseases. So therefore, I thought, if the method of exercise is much more well recognized, then we are more able to provide a more wholesome, balanced treatment for attention to the patient. Therefore, hopefully with this, we can have a meaningful outcome to the patient. Therefore, they can have a better quality of life. Okay, so this is the end of my talk. Once again, thank you for the opportunity, and thanks a lot. Bye.
Thank you, Dr. Goh. You have been with us for a couple of the conference, and we have a question for you here. It says, good afternoon. My question is, I suspect that I have UTI, but then after done a urine test, the result shown normal and no infection detected. The thing is, even sometimes I have pee blood and I feel burning sensation when I pee. What could it be?
Hi, Dr. Lee, can you hear me?
Hi. Yes, I can.
Yeah, so this is a very common scenario. Because the urinary tract infection is one of the common things that we see. 1 jam, sibuk. Siap juga, sekejap. Jangan sibuk ni. Aku baik-baik. Sorry, opportunity. Sorry. Yeah, so what I'm saying is that there are a lot of things that actually mimic like a infection, but they're actually not infection. It could be a stone in the urine tract, or it could be a tumor, or it could be just a bladder which is just being too active. So a lot of patients, they come to us with the impression having an infection, but they're actually not infection, something else. So that's why depends on the patient's multiple exposure, the risk side, age, the background, and also the social event. Then we may have to investigate the next step of investigation, like either a scope or some sort of test. Yeah. So therefore, not always an infection, but if it is not, well, even after the course of antibiotics, I think that somebody should reconsider another opinion or further assessment. That's all I can say. Okay.
Great. Thank you. We have another question here. Can electrolytes drink cause stone formation for long distance cyclists? You mentioned sports drink does cause stone formation.
Yeah, so I have read a few things. Of course, there's no. I mean, I haven't seen any like names mentioned, but usually they describe like the isotonic sports drinks. Yeah, so theoretically, because the content, for example, sugar, the fructose, so associated with stone formation. So if you ask me, not just long distance cyclists, I mean anybody who indulge in too much of the good things, eventually they might just get the bad things also. So therefore, I think it's about moderation.
Yeah. Great, that's a good answer, because a lot of athletes really do not know how to gauge themselves in terms of electrolyte drinks because of the marketing strategy by the product people. That's a good answer.
True.
Yeah. Right. Is there any other questions here? You have Dr. Gore right in front of you. This is a very common thing that athletes will always face in terms of that section of the urology aspect.
Another thing which is quite common is that sometimes among gym colleagues, they might just go for supplement. And then I believe a lot of these, they have the hormone inside, which is the testosterone. Again, not something which is recommended, because if it's taken not for the appropriate reason, it can cause a lot of side effects. So therefore, sometimes supplements or any hormone to boost the muscle, clearly it is not advisable.
I think especially the hormonal things that, like testosterone, a lot of bodybuilders, they're onto it. Yeah.
That's right.
Okay, good, thank you. I think there's no more other questions. So Dr. Goh, there's one more. What type of patients are suitable for lithotripsy?
Oh, lithotripsy. Okay, lithotripsy, it means stone breaking. To select whether someone is suitable for what kind of treatment, it has a lot of things to consider. The patient factor and the stone factor. So patient factor, for example, how painful it is, and then the kidney function, and also about the social background. Sometimes when a stone is not so big, we should just monitor. But someone who travels a lot, like flight attendants or pilot, or some who work offshore, in oil and gas industry, or in the shipping industry, or someone who is trying to get pregnant. So even when a stone is still a bit small, there's always a discussion, whether want to go ahead with the operation, because if the stone gets stuck, it's very painful, and the emergency evacuation can be expensive. And if someone is pregnant, so sometimes the surgery is hard to do because there's a baby inside. So otherwise, the treatment for stone, there are quite a lot of choices. Either we just go for the shockwave externally, or the surgery, which is to go inside. So if someone go for shockwave, there are things to consider, like the stone hardness, the stone size, and the skin stone distance. Or sometimes small stone we just monitor and might just pass out spontaneously. So it's just a lot of things that I consider, not just look at the image and decide what to do next.
Okay, good. Thank you for your answer. All right.
Okay, thanks a lot.
I think that's it. Thank you, Dr. Goh.
Okay, thanks a lot.
Yeah, all right, bye-bye.
Bye.
Okay. I think delegates and ladies and gentlemen, I think we are very lucky that we have Dr. Goh here, as he is more than willing to answer questions that is in relation, not directly to your sports, but to your health as a urologist. Okay, is Dr. Sean Galloway in the room? No. All right, I think we are expecting the next paper is supposedly to be Dr. Sean Galloway. Now, I know he has been extremely busy at his institution. I think there's a new intake of students. But nevertheless, if he's not in here, we're going to move the paper upwards. Is Dr. Siva in the room now? Also not in the room. No? Pre-record. Okay. We will proceed on to the next paper, which is scheduled at 3 p.m. We're going to bring it up because Dr. Sean is supposed to do it live. He's not in yet. So we're going to play the recorded recorded paper of Dr. Siva Neswaran on the paper topic as lifestyle medicine to prevent the perfect storm. Dr. Siva is the founder and the president of the Malaysian Society of Lifestyle Medicine. Right? He is advisory board for the International Journal for Disease Reversal and also Prevention. He's a national coalition for mental wellness in Malaysia, as well as the True Health Initiative Council, a global positive health institute advisory council. So this year, Dr. Siva has joined us, and he's going to share with us what is lifestyle medicine and how lifestyle medicine can actually contribute to better health. Now, as you can see, every year we have more and more topics and more discipline that appears in the exercise medicine realm. Exercise medicine, it covers a lot of areas, and as we all know, our objective is to fight NCD, and lifestyle medicine is very appropriate towards the combating of NCD. Right. So let us listen to Dr. Siva's paper now.
Welcome to our session on lifestyle medicine, a prescription to prevent the perfect storm. COVID-19, first discovered in Wuhan, China, has now spread world over and has resulted in 246 million people being infected with the virus and 5 million deaths thus far. Now, an uncontrolled COVID-19 infection can trigger a cytokine storm. So what is a cytokine storm? In a cytokine storm, what happens is that there are the pro-inflammatory cytokines and chemokines are overproduced by the immune system. Now, this results in multi-organ damage and coagulation abnormalities that can lead to thromboembolic events. Now, this can present as comatose, stroke, heart attack, cardiac arrest, embolism in the lungs, and Kawasaki syndrome in children. Now, when this uncontrolled COVID-19 infection or the cytokine storm takes place in a person with a chronic disease, this sets the stage for a perfect storm where this uncontrolled inflammation is aggravated. Now, in a study published in the Lancet Global Health, it is suggested that 1 in 5 people are at an increased risk of severe COVID-19 should they become infected, mainly due to underlying chronic diseases. So why does this perfect storm occur in people with chronic diseases, or more likely in people with chronic diseases? Because fundamentally, people with chronic diseases or NCDs have a dysfunctional immune system. They have an impaired immune response to infection. There's an increase in inflammation, there's ongoing chronic inflammation, and it is prothrombotic in nature. So when you have an acute infection, such as COVID-19, taking place in the background of chronic diseases where there's ongoing chronic inflammation with a compromised immune response to infection, this leads to the perfect storm. Let's look at some data on COVID-19 and NCDs. So what is the risk factor for the severity of disease in people with diabetes? Twofold increase. What about risk factor for hospitalization? 12 to 16% increase. And mortality, threefold increase in patients with diabetes. Moving on to COVID-19 and hypertension. Hypertension is the most common comorbidity, and twofold increase noted twofold increase in severe cases in ICU. Now, COVID-19 and obesity. UK Biobank data shows that being overweight increases the risk of COVID-19 by 44%. And in a study, it showed that 41.7% of hospitalized patients in New York City Hospital were individuals with obesity. Now, the data that we are talking about today is not new. This has been seen in previous pandemics in the past 20 years. The past 20 years, we have seen SARS, influenza A, and MERS. And time again, we've seen the same scenario. Now, this scenario is repeating itself because, unfortunately, the NCDs continue to rise. And so when we hit the next pandemic like we did now, right, the same scenario plays out again, increased morbidity and mortality in patients who have chronic diseases. Now, COVID-19 will cease at some point, but at some point in the future, we will again face another pandemic. So what's going to happen again? Now, the chronic diseases currently are rising at an alarming rate. And again, patients with chronic diseases will be at the risk of the perfect storm or an aggravated cytokine storm, which will increase their morbidity and mortality. So basically, the NCDs are drivers of these pandemics, and we need to address these drivers of the pandemic, and we need to address the drivers of the pandemics way before the pandemic comes into place. So how are we going to address these drivers, these chronic diseases? So of course, the first thing that we want to do is we want to try and prevent the rise and in fact reverse the trend, right? So we want to look at people with hypertension, hyperlipidemia, coronary artery disease, diabetes, obesity, right? And of course, we want to make sure that our immune system is enhanced and optimized. And when we are talking about an optimized immune system, we always need to take into account our gut flora, right? Our gut flora is very important as part of the immune system. We'll talk a little bit more about that in a while. All right, the good news is that 80% of lifestyle diseases can be prevented, managed, and reversed. Our immune system can be enhanced. The question is about doing the right thing. And so how are we going to do the right thing, right? So lifestyle medicine is an intervention, all right, that helps us to prevent, treat, and even reverse diseases and boost our immune system or enhance our immune system by replacing unhealthy behaviors with positive ones, right? So lifestyle medicine is an evidence-based therapeutic intervention that promotes the use of a predominantly plant-based diet, regular physical activity, sleep, stress management, avoidance of tobacco, and moderate alcohol consumption, and positive social connectivity. Now, looking at diet and nutrition, well, many studies show that diets high in saturated fat, sugar, refined carbohydrates contribute to the prevalence of obesity, type 2 diabetes, and more. This, of course, increases the risk of severe COVID-19 pathology and mortality. It impairs the immune system. Okay? And so, in order to address this situation, we need to change the way that we are eating. So, what is prescribed is a whole food plant-based diet, right? Where half the plate is filled with fruits and vegetables, the quarter of the plate has plant proteins, and the other quarter of the plate has whole grains. Now, incorporating plant proteins is important because plant proteins are not only high in fiber, for example, the legumes, all right, but they also are converted to short chain fatty acids. This fibers helps to convert into short chain fatty acids, which produces butyrate, and this helps us with the management of chronic diseases. Now, published studies show that intake of fruits and vegetables, which are rich in antioxidants, which are anti-inflammatory in nature, which are rich in vitamins and minerals, are associated with a lower risk of inflammation. They are also able to importantly modulate the immunological response. So modulating the immunological response becomes very important in situations like COVID-19, where the immune system is too ramped up at some point, right? And also helps to reduce the inflammation. Of course, a plant-based diet contributes to the lower risk of heart disease, diabetes, cancer, and more. Now, evidence also suggests that large amounts of fruits and vegetables and a small amount of meat consumption can reduce the risk of thromboembolism. Again, this is important considering the fact that in COVID-19, especially against the background of chronic diseases, clotting is an issue. Now, as we live with COVID-19 or as the pandemic stretches on and as people recover, we are beginning to see that there is a group of patients who are suffering from long COVID. And it's also postulated that the peripheral inflammation caused by COVID-19 may have long-term consequences, which may lead to dementia and neurodegenerative diseases. We know that neuroinflammatory mechanisms can be compounded by an unhealthy diet. Hence, having a diet that's anti-inflammatory in nature, which is plant-based, helps to reduce the inflammation, helps with the healing associated with long COVID. Let's talk a little bit about our gut microbiome. So our human body is host to more than 100 trillion microorganisms. They play a role in our health, and they can play a role in disease state as well. Okay. Now, A large portion of our immune system is in our gut. Now, this is our first line of defense. Now, we should have a proportion of approximately 70% good bacteria and 30% bad bacteria. But if our lifestyle is not optimized, what's going to happen is that we are going to have a imbalance in the gut bacteria. So we're going to have dysbiosis. So having dysbiosis means poor immune system. So optimizing the gut bacteria will help to improve the immune system. This will help us ramp up our immunity towards the infection. It also has a role to play in it being anti-inflammatory. Not only that, it has now been shown that the gut bacteria can play a role in preventing chronic diseases or helping to manage chronic diseases, for example, like diabetes, obesity, and more. And vitamin D, this is an important vitamin that we may want to talk a little bit about. So vitamin D3, which is inactive, is produced on exposure to sunlight and converted to the active form in the liver and kidney. So food sources of vitamin D are a little limited, okay, mushrooms, milk. And as we age, our ability to produce vitamin D3 is reduced. Now, the important function of vitamin D is that one is that it is immunomodulatory. Again, it's able to ramp up when it needs to ramp up and is able to ramp down when it needs to ramp down. And it inhibits inflammation. Hence, it plays a significant role or can play a significant role in the management of COVID-19 and chronic diseases. Now, in a study done in the University of Chicago, they found that patients who had vitamin D deficiency and were not treated were twice as likely to test positive for COVID-19 infection as compared to the group that had sufficient levels of the vitamin. Now, again, another study shows that the lower the vitamin D levels, the higher the incidence of morbidity and mortality. So negative correlation between vitamin D levels and mortality and morbidity. Curcumin. Curcumin is a herb that we may want to incorporate into our diet. It is an extract from turmeric. It has multiple health benefits. It is primarily acts through its antioxidant and anti-inflammatory mechanism. So it is a very powerful anti-inflammatory herb. Best taken when it's combined with pepper, which is called piperine, and it is something useful to incorporate into our diet. Now, moving on from diet and nutrition to physical activity. So as we evolved, as man evolved, what happened is that we became more and more sedentary. As technology evolved, we became more sedentary, right? Now, as we became more sedentary and only exercise our fingers on our computers, tablets, and smartphones, what happens is that we increase the risk of physical and mental illnesses. So a sedentary lifestyle has an increased risk of physical and mental illnesses and also compromises our immune system. In fact, sitting is the new smoking. Now, physical activity is responsible for between 6 to 10% of NCDs, and due to the lockdowns world over, inactivity has been accentuated and worsening of medical conditions. Okay, so incorporating physical activity into our daily life will help us with our mental health, will help us with our physical health, and will help to boost our immune system. So 40 minutes, 5 times a week. So we'll have about 200 minutes. Optimum should be about 210 minutes a week of exercise. Now, some studies show that moderate intensity exercise reduces inflammation, improves immune function, and decreases the risk and severity of respiratory infection. Now let's move on to stress. So what's the relationship between stress and disease? So as stress activates our neuroendocrine and sympathetic pathways, okay, resulting in the production of cortisol, adrenaline, and noradrenaline. At the same time, what happens is that the parasympathetic nervous system is inhibited. The neurotransmitters, serotonin, dopamine, and GABA are also inhibited. We have gut dysbiosis. There's increase in oxidative stress and inflammation, impaired immunity. Stress is also linked to abdominal obesity, insulin resistance, impaired glucose tolerance, abnormal lipids, endothelial dysfunction, vascular complications, and poor mental health. So how are we going to deal with the stress? Pre-COVID, we had a huge amount of stress. Now with COVID, the stress levels have increased for various reasons. The first thing that we want to do is we want to look at resetting our mind, because some situations we can't change. We don't have the control to change situation, but we have the ability to reset our mind, to reframe how we are going to look at things. Whether we want to be mindful, full of clutter in the mind and excessive thinking, or whether we want to declutter the mind and become mindful, taking only what we want to think about and having more peace in our lives. So mindfulness, as defined by Dr. John Kabat-Zinn, the father of mindfulness, is a psychological process of bringing a person's attention to the current moment. And this can be developed through the practice of yoga, meditation, and other training. So what happens, right, is that we need to build a resiliency kit. And one of the things that we want to put into the resiliency kit are mind-body intervention techniques such as mindfulness, yoga, guided imagery. Now, when we put that into our resiliency kit, okay, we downregulate the amygdala, which is our stress sensor. Once the stress sensor is downregulated, this decreases the production of stress hormones and inflammatory cytokines, promotes healthy gut microbiota, increases the production of neurotransmitters such as serotonin, dopamine, and GABA. Right? Now, what happens here basically is that we are evoking the body's natural counterbalance, the relaxation response. The relaxation response is evoked when the parasympathetic nervous system or the vagus nerve is activated. Now, in this state, we have a state of deep rest, and this brings about the changes that stress brought upon. Okay, the changes that stress brought about. So, in this state, the breathing rate goes down, blood pressure goes down, heart rate, blood sugar, etc. goes down, and the immune system improves, creativity, concentration increases. Now, if we look at some studies, now if we take yoga therapy as one example of a mind-body intervention technique that we want to use. So yoga therapies reduce salivary cortisol levels. There are many studies that show that mind-body intervention techniques reduce cortisol levels. And yoga practice, where they compare novice and expert yoga practitioners, it's found that in the novice practitioners, serum interleukin 6 is 41% higher. So that means they're just beginning. They haven't been practicing yoga as compared to expert yoga practitioners, right? And they have a detectable CRP, which is 4.75 times higher than the expert yoga practitioners. Also, other than mind-body intervention techniques, other things that we can do to manage our stress is doing things that we like: singing, dancing, playing some games, right? Don't take life too seriously, have a good sense of humor, and connecting with nature. Connecting with nature is very good, is a very good stress buster. And the added benefit is that if you also expose yourself to some sunlight, right? Now this helps with our vitamin D. Vitamin D is also useful for our mental well-being, right? Now, studies show that if you don't get enough sleep, right, a person is most likely to get sick after being exposed to a virus because the immune system is compromised, and also recovery becomes slower. So chronic stress is also associated with an increased risk of metabolic disease. A large study done in the United Kingdom by Chandler showed that workers who do night shift continuously have higher levels of cortisol and are more predisposed to metabolic diseases. Now, social connectivity. Social connectivity has been shown to improve longevity and physiological parameters. How does it work? It activates our parasympathetic nervous system. So when I say social connectivity, it's actually connecting with people, not being connected on social media. In fact, excessive use of social media shows that there's an increased risk of anxiety and depression. So a very interesting study, which I would like to share with you. This is a 75-year cohort study where they compared Harvard male students and men from inner city Boston. So the comparison is these young students who have everything. They are going to a prestigious university, they will come up, they'll get a good job, they will get good salary, and the guys from inner city Boston who basically don't have anything. Now, what they found was that the single most important predictor of happiness and longevity was the social connectivity. It was not their education, it was not how much money they had. So this is very important, especially during this time of COVID-19, where, world over we've had various stages of lockdowns, which was essential to manage the situation. But this disconnect causes issues as well. And in a technologically advanced world, we are actually disconnected from people, right? So we need to put more emphasis on connection with people in person, either talking or seeing people, and not just being connected on social media. So in conclusion, ladies and gentlemen, the global response has been to treat COVID-19 as a vertical disease rather than addressing COVID-19 and its interaction with NCDs. Given the interaction between COVID-19 and NCDs, it is important to address the underlying drivers of the pandemic that are fueling the COVID-19 mortality. Lifestyle medicine is an intervention that will help address the drivers of the NCD pandemic and help to enhance immune system, which will help us to combat COVID-19 and future pandemics. Stay safe and stay healthy, ladies and gentlemen. Thank you.
Okay, thank you very much, Dr. Siva. Welcome to the conference. You have a questions here. Does exercise in the context of immunomodulation and the many benefits in lifestyle medicine also include strength training, resistance training, or is it primarily from aerobic exercise or cardio in this context?
Hi, Dr. Lee. Good evening.
Hi.
Good evening, everyone. Okay. All right. When we talk about, I'm going to just break the session into two parts. So in lifestyle medicine, when we talk about exercise, we are talking about the three components: aerobic, strength training, and flexibility. So to answer the question about strength training and immunomodulation, so I think there are some published research that shows that strength training helps with immunomodulation to do with gene expression. Okay, so down regulates the inflammatory gene, so it helps with reduce CRP, reduce interleukin 6. So some studies have published that's that. All right.
Okay, thank you. There's another question here for you. We know sleep is important to reduce stress and recovery, etc. Can you give suggestion how to have a deep sleep or quality sleep? Good. I'd like to hear from you too.
Okay, all right. So I think one of the things that we want to do in terms of having good and deep sleep is to regulate our sleeping time following the circadian rhythm. Okay, so say about 2 to 3 hours before your sleep time. And when I say sleep time, we are looking at the regular bedtime of 10 to 11 and waking up 7 hours. So some people sleep at 3 hours, up at 7 hours later. So that's not considered good sleep. That's the first thing. So about 3 hours before that, you want to stop caffeinated drinks, and you want to, and an hour before you go to bed, you should stop looking at your phone and any devices. Okay, you are cutting off the blue light because it's actually a stimulant. Can you hear me now?
Yes, we can hear you.
All right, okay. So, I'll just recap because I think somebody commented that they can hear me. All right, so basically, so 3 hours before bedtime, you should actually cut down on caffeinated drinks, no caffeinated drinks. 1 hour before bedtime, right? No screen time, no checking the phone, no exposure to blue light, okay? And no TV, okay? And you can also have a drink drinks like, say for example, like milk, which releases tryptophan, or herbal drink like chamomile, which is a relaxant, which has a relaxing effect, and that will help you with better sleep. And your again, then you should try and do some exercise in the early part of the evening.
The sound is someone's. I think it's his microphone.
All right. You should also have some exercise the early part of the evening, and your waking time in the morning, all right, again should follow the circadian time. So you should wake up, at the when there's sunlight, you should be awake. Okay, so that way you'll be able to regulate your body's rhythm and have good sleep. Okay.
Okay, you have two more. We can go for another two more questions. You strongly recommend a plant-based diet. Is that vegetarian or vegan diet? The issue about lacking essential protein for muscle health can cause long-term detrimental effect. One of them is also cause anemia, calcium deficiency as side effect. How do you address this? Yeah, I think it's quite.
All right. So when I'm talking about a plant-based diet, all right, I think the issue here is not that we are overdoing. I'm not particularly advocating vegan, all right, or vegetarian in the sense that so long as you incorporate half your plate, first thing is half your plate should be vegetables and fruits, because basically what we are doing is we are under eating. Number two, what I'm suggesting is that you incorporate legumes, because legumes have benefits of their own. High fiber, which helps with the production of short chain fatty acids, butyrate, right? Now you can eat meat and fish, okay, but they should be more of condiments instead of the other way around. So what's happening now is that we have maybe half or three-quarter of the plate filled with meat, carbohydrate, etc., and very little vegetables or fruits. That's the first thing. Secondly, when you're talking about deficiency in calcium, say like vegetables like, for example, broccoli have high amounts of calcium. And if you're not a vegan, okay, which I'm not advocating, then you can have your dairy sources for your milk, and you can still have, and legumes are also rich in protein as well. So if you eat a balanced plant-based diet where you're getting your proteins, say from legumes, and you can of course add on if you want to, then you shouldn't be deficient in your proteins. But if you are going to be vegan, then that's another discussion altogether, which is not what this topic is about. Okay, I hope that helps to clear up that doubt.
All right, you have one more. Can you provide links to those studies showing the benefit of strength training on immunomodulation?
Yeah, okay. Yeah, I can. How would I do that now?
I think what you can do for these questions, those who are asking some information or reference paper from Dr. Siwa, what we'll do is that we will give you the email. Yeah, you just type your email, and then type your email in the chat box, and then Dr. Siwa will pick it up and he will send to you. Okay. Is that all right, Dr. Siva?
Yeah, that's fine. Yeah, if they can share their email, I'll send it to them.
Yeah, you share the email. Those who want those reference paper. So that goes for everyone. If you need any things from the speaker, just ask the speaker. In particular, only for reference papers. Right? Slides and his papers presented will be into the YouTube of the World Conference. Okay, I think the rest of the questions are quite similar. Then, okay. So thank you very much, Dr. Siwa. All right, and I understand that your conference is also getting close, isn't it, Dr. Siwa?
Yes, Dr. Lee. We are hosting our inaugural Lifestyle Medicine Conference on the 4th and 5th of December. I'll share the flyer with you a little later.
Sure. Yeah, you can also share it here so that some of the people here can also join the conference. Okay. We are very share to get knowledge for everyone.
Sure.
All right. So thank you very much.
All right. Thank you. Thank you.
You're most welcome. Thank you. All right. Bye-bye. Okay. I think now it's time for us to get up and do a little bit of exercise. We have someone all the way from Sabah, is it? Sabah from Ranau, is it? Keningau, okay. Keningau. He is a student of my college, and he is back in Sabah doing his internship. And he volunteered to do this X-break. right? X break, like I said, is a short exercise that everybody get up to exercise a bit after sitting more than 2 hours. His name is Azharuddin Arshad. All right, he's a final year student of a college, and he's doing his internship at One Fitness Gym. Right, most of our students, they all have their internship at the fitness centers or the gymnasium or at the health promotion center of the Ministry of Health. Okay, let's proceed. The X break.
Assalamualaikum and hello everyone. Greeting from Malaysia. My name is Azharuddin, internship student of Asia College Exercise, Sport and Medicine. Alright guys, let's do some stretching to relax our muscle after sit a long hour today.
Okay. Thank you very much to Azharuddin. The exercise that you showed just now, I have to do it with my little daughter. You see. That's a new lifestyle medicine, you see. Doing exercise with a little girl for all parents. All right, we are going to break up into two rooms now. The one room will be the Symposium on Exercise and Metabolic Diseases. The chairman of this symposium will be chaired by Dr. Bradley Elliott. He will be the chairman for this from the United Kingdom. And the other room will be room 2, supposedly to be chaired by Dr. Sean Galloway. Unfortunately, he is still not around, but this room will be chaired by Dr. Said Rehan Bukhari from Pakistan. I will introduce Dr. Rehan for his paper. All right, so do we go to now? Let's go to Dr. Rehan. Are we going to room now? Yeah, set my room to room 2.
Pick up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. Here is where we stand. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life Pick up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. Here is where we stand. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Oh, let your steps pick the way for the future. 'Cause you're alive, inspiring others. Don't you lose your hopes due to hurt and loneliness. 'Cause there's always another way. And all the nation together as one, fighting for a brighter future. Gathering all our brothers in arms, here we will stand tall. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Just keep moving. Just keep moving. Just keep moving. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Yeah. Pick up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. Here is where we stand. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Oh, let your steps pick the way for the future. 'Cause you're alive, inspiring others. Don't you lose your hopes due to hurt and loneliness. 'Cause there's always another way. And all the nation together as one, fighting for a brighter future. Gathering all our brothers in arms, here we will stand tall. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Just keep moving. Just keep moving. Just keep moving. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Oh, yeah. Pick up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. Here is where we stand. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so
Hi, ladies and gentlemen. Sorry for the delay. We can see Dr. Bradley Elliott here, but we could not contact him. Anyway, I'm going to chair this session for you all here. Wow, we have 100 over people over here. Okay, the abstract for today is an exercise and metabolic diseases. We're going to have the first paper, Miss Gayatri Patel from India. The paper is on, oh, sorry. This is Zoom 1. Oh, okay. Sorry. Apology. It's exercise and metabolic diseases. And your first paper will be Dr. Soo Jong Kim from the United States. And he will be delivering a paper on newly discovered mitochondrial mutation on the MOTS-C region increases the risk of diabetes in Japanese men. Right, Dr. Soo, you can start.
Thank you, organizers, for giving me a great opportunity to share my work. I'm delighted to talk about a subject that I think we are all very passionate about, which is the importance of exercise for helping people age better. And I'm trying to give you a mitochondrial perspective why that's the case. At the end of the talk, I hope you learn about the novel class of mitochondrial microproteins and how exercise interacts with mitochondrial SNP through mitochondrial peptides. I like to do my acknowledgement before I get started. There are a lot of people who I've worked with over the years who contributed in various ways in the research that I'm going to talk about today, including funding organizers. I especially thank Dr. Kumagai, who is an exercise physiologist, inspired me to test the exercise and muscle physiology. Mitochondria are double membrane organelles that generate cellular energy. Various forms of metabolic stress, including exercise, triggers response in muscle mitochondria that result in signaling to other cellular compartments or tissues. Different types of exercise can provide a powerful stimuli for mitochondrial biogenesis. Mitochondrial degradation by mitophages interact with mitochondriogenesis too. Intermediate metabolite derived from mitochondrial metabolism signal to the mitochondria from the mitochondria to the nucleus, resulting in epigenetic modification to regulate gene expression, like acetyl-CoA. Many studies shows that muscle mitochondrial function and quality control influence systemic metabolism. The idea is that muscle does not only move our body, move our joints, but it's actually a secretory organ. So muscle secrete things locally and secrete things into blood. These so-called mitokines that are these positive regulators of metabolism, and they have positive effect on fat, on liver, on pancreas and bones, etc. Mitokines can release from the cells with stress mitochondria. So the question is that are any of mitochondria peptide mitokine that mediate exercise beneficial effect? So I want to talk about how the evidence we have that a mitochondria-derived peptide called MASI might be acting as an mitokines. Traditionally, mitochondrial DNA known to encode 13 mRNAs, 2 RNAs, and 12 tRNAs. However, emerging study shows that small off-reading frames and non-coding RNAs in the mitochondrial DNA encode microproteins. Mitochondrial peptide refers to short protein less than 100 amino acid encoded from the mitochondrial DNA. Currently, 8 mitochondrial peptides are published and more are to come. MASI is a mitochondrial peptide encoded from 12 siRNA region of the mitochondrial DNA. MASI is well conserved across various species and expressed in various tissues, including heart, liver, and muscle. MASI is secreted into bloodstream and measured in plasma from human red mouse. MASI administration increases AMPK and its downstream pathways in vivo in vitro. Like other mitokines, MASI reduced body weight gain, improved insulin sensitivity, and increased energy expenditure in obese mice. Moreover, MASI levels in skeletal muscles and circulation go down with age. MASI levels decline with age. Aging is accompanied by a progressive decline in mitochondrial function and loss of metabolic homeostasis. This study aims to investigate whether MASI improves physical activity and health span in old mice. To increase the circulating MASI levels in old mice, investigators daily inject old mice with MASI and measure the exercise capacity. MASI-treated mice ran significantly longer in the treadmill running test. In a long-term study done by the same investigators, MASI improved grip strength, gait and physical performance by walking test. These results suggest that MASI treatment improves overall physical capacity in old mice and may compress mobility and increase health span. MASI increase AMPK and sirtuin signaling pathways and share the benefits of exercise. Dr. Mary at the University of Auckland examined whether MASI responds to physical exertion, thus may be involved in driving adaptation to enhance physical activity. They recruited sedentary, healthy young male volunteers and exercised on them stationary bicycle. Muscle and plasma samples were collected before, during, and after exercise and following a 4-hour rest. MASI levels in skeletal muscle and circulation increase after exercise. Not only acute exercise, but also chronic exercise increased MASI levels. In this study, we measured MASI levels in human after 3-month exercise program and found MASI levels increase about 6-fold. In a collaboration with Dr. Deli Conrad, we measured circulating MASI levels from breast cancer survivors who had a 16-week aerobic and resistance exercise intervention. MASI levels significantly increased in non-Hispanic white breast cancer survivors following exercise intervention. Moreover, post-exercise levels of MASI were associated with improved cardiometabolic biomarkers, contributing to the overall positive impact of exercise on a population of cancer survivors highly prone to cardiovascular-related comorbidities. Now, I want to shift toward a mitochondrial SNP in the coding region of MASI, and which increase the risk of type 2 diabetes. This map shows the prevalence of type 2 diabetes in 2019. An estimated 1.5 million deaths were directly caused by diabetes. 5 studies used here investigated whether a specific mitochondrial SNPs contribute type 2 diabetes prevalence in different ethnicity. Although the association is strongly studied in population genetics, the functional effects of the mitochondrial SNP are underexplored. Investigators speculated that mitochondrial SNPs can potentially affect mitochondrial function and the cellular metabolism, leading to the alteration in insulin secretion and beta cell function, and may explain why type 2 diabetes prevalence is different between ethnicity. However, a majority of mitochondrial SNPs are synonymous with respect to the large mitochondrial genes. So our lab hypothesized that mitochondrial SNPs impact on mitochondrial peptide sequence and function and may explain type 2 diabetes pathophysiology. So we found an East Asian specific mitochondrial SNP that is located in the MASI coding region. The frequency of the SNP varies from 5 to 8% of East Asian. A meta-analysis of the 3 cohorts shows that MASI SNP increased type 2 diabetes risk only in Japanese men, but not women. The SNP did not change the predictive structure of the 12S RNA region, but it caused amino acid replacement of lysine to glutamine at the 14 amino acid residue in the MASI peptide. In other words, individuals carrying the SNP produced K14Q MASI instead of wild type. So we investigated the relations between SNP and type 2 diabetes pathophysiology by examining the difference between wild type and K14Q MASI. We employed both forms of MASI in several in vitro models to test the possibility that the altered structure of MASI resulting from the K14Q mutation will lead to changes in the activity of the peptide. Since MASI has been shown to increase insulin sensitivity in vitro and vivo, we assessed the effect of K14Q MASI on cellular insulin action. C2C12 myotube treated with insulin increased the phosphorylation of AKT, and wild-type MASI increased further the AKT signaling. However, K14Q MASI treatment was the same as the control group. Moreover, the wild-type MASI increased glucose uptake, whereas K14Q MASI was less effective in enhancing insulin-stimulated glucose uptake than wild-type. Insulin plays an important role in adipocyte differentiation. So we used T323L1 pre-adipocyte differentiation as another model to assess insulin sensitivity. During differentiation, we treat cells with wild-type and K14Q MASI in the presence of insulin. So wild-type MASI, but not K14Q, increased repeat roughly during adipocyte differentiation. Next, we examine the effect of K14Q MASI in high-fat diet-fat mice. Previously, MASI reduced body weight gain and fat mass by improved insulin sensitivity in skeletal muscle and increased energy expenditure in high-fat diet fat obese mice. We confirmed this effect as wild-type MASI reduced the weight gain in high-fat diet fat mice. However, K14Q MASI has less effect on weight gain and remains similar to the control group. Body fat also did not increase in high-fat diet fat mice administered with wild-type. K14Q MASI administered mice gained fat mass similar to the control group. Lean mass did not change, so the reduced body weight gain may be caused by less fat mass as MASI increased fatty acid metabolism and energy expenditure. Although body weight was altered, food intake from wild-type and K14Q MASI injected mice remained the same as control group. In a glucose tolerance test, wild-type MASI enhanced glucose clearance, whereas K14Q MASI remains same as control. These results suggest that K14Q MASI is less effective in vivo compared to wild-type in male mice, and K14Q MASI is an inactive form of wild-type MASI. Our meta-analysis shows that wild-type MASI SNPs are predisposed only men to the type 2 diabetes. We examine the potential sex differences in MASI effect in mice. Unlike male mice, female mice fed with a high-fat diet did not respond to wild-type MASI treatment. Female mice injected with K14Q MASI showed no effect either. Fat mass, lean mass, food intake, and glucose tolerance tests were also not altered in both wild-type and K14Q MASI female mice. Hormonal differences between males and females could interact differentially with MASI on metabolic function. A study done by Dr. Liu shows the MASI did not change the metabolic phenotype in female mice with normal hormonal function, similar to our finding here. But MASI improves metabolic function in overrectomized female mice. These results suggest a link between ovarian hormones and the effect of MASI. Thus, it could be clinically relevant to identify what sex-specific factors permit females to overcome the potentially harmful effect of MASI SNP on type 2 diabetes seen in men. We expanded our analysis by looking at the effect of aging and exercise on the MASI SNP and type 2 diabetes risk. Analysis in JAMIE cohort shows that MASI SNP increased the risk of type 2 diabetes in older individuals who are older than 64 years. To understand the interaction between age and type 2 diabetes risk, we hypothesized that MASI SNP might be associated with skeletal muscle fiber type. Human skeletal muscle is classified as type 1 and type 2 with subgroups type 2A and 2X. Type 1 slow twitch fibers are fatigue resistant and focused on sustained smaller movement. They contain more mitochondria and are aerobic compared to fast twitch fibers. Fast twitch fibers provide bigger and more powerful forces, but the shorter durations and fatigue quickly. Fast twitch fibers are more anaerobic with less blood supply. Skeletal muscle contains both fibers, but the ratio can differ depending on various factors, including muscle function training, age, and sex. Slow twitch fiber support long-distance endurance activities like marathon running, while fast twitch fibers support quick, powerful movements such as sprinting or weightlifting. During aging, fast twitch fibers age more rapidly than slow ones. Study shows that a higher percentage of fast twitch fibers associated with increased risk of chronic disease, including cardiovascular disease and type 2 diabetes. Sexual dimorphism present in the muscle fiber types. The percentage of slow twitch fiber is higher in females compared with males. Based on the difference of muscle fiber types, we hypothesized that MASI SNP is associated with higher percentage of fast twitch fibers, so MASI SNP is at higher risk of type 2 diabetes during aging. So we measured muscle fiber composition from 200 Japanese men and women. The contractile speed of myosin heavy chains directly contribute the speed and power for its total muscle type is capable of exerting force. Thus, the slow myosin heavy chain 1 is found in slow twitch fibers, and the fast myosin heavy chain 2A and 2X are found in fast twitch fiber. We measured the percentage of these myosin heavy chains from MASI A and C allele carriers. The A allele carriers tend to higher tend to show higher MHC1 isoform than C allele carriers, while C allele carriers show significantly higher MHC2X composition than A allele carriers. Slow twitch fiber support long-distance insurance activities, while fast twitch fibers support powerful movements. Interestingly, the C allele frequency was higher in sprint powerful athletes and lower in endurance athletes compared to the controls. As our study shows that MASI-K14 generated from the C allele is a bioinactive form of wild-type MASI. So we inject the MASI neutralizing antibody to suppress the MASI action in young mouse. After a month, MASI neutralizing antibody treated mice exhibited higher MHC2X, which is a fast twitch fiber expression in skeletal muscle. So higher percentage of fast twitch fiber in MASI SNP carriers could contribute to the increase of type 2 diabetes risk during aging, since fast twitch fiber age faster than slow twitch fiber and increase the risk of chronic disease. Thus, the amount of exercise contribute to type 2 diabetes in MASI SNP carriers. We took advantage of the accelerometer-based measurement of daily activity in the GMX study. Moderate to vigorous intensive physical activity, MBPA, is correlated with lower risk of type 2 diabetes in men with the C allele. Moreover, the MASI SNP increases type 2 diabetes risk mainly in sedentary males. The effect of the SNP is male specific, as sedentary females with the C allele did not have an increased type 2 diabetes risk. The results suggest that higher MBPA rescues the potentially harmful effect of the MASI SNP on type 2 diabetes risk in men. Thus, exercise could be a significant beneficial intervention for C allele carriers of this SNP. Developing optimized exercise guidance for people with the MASI SNP could be clinically translatable. It is compelling to hypothesize that MASI is an exercise mimetic peptide that helps prevent type 2 diabetes in sedentary men. In contrast, in men who are frequently exercises, there is no further metabolic benefit of MASI or further protection from type 2 diabetes by MASI. However, the bioinactive K14Q MASI may increase type 2 diabetes risk, particularly in susceptible sedentary group. In evolutionary perspective, we propose that K14Q MASI evolved to best fit the living conditions characterized by highly active lifestyles and limit calorie restriction, where K14Q MASI increase fast twitch fiber and might present advantage. But in 21st century, it is a metabolic liability. So I think an ambiguous implication is that as we contribute, explore ways to prevent type 2 diabetes and promote health aging, our primary goal must remain to promote physical activity, especially among sedentary individuals carrying a MASI SNP. In Japan, today adults spend 20 million MBPA per day on average. In Korea, only 20% only meet the recommended daily 60 million MBPA activities. So our study shows that average 40 minutes per hour MBPA rescues the potential detrimental effect of the MASI SNP on type 2 diabetes in men. So with that, I hope I've given you a kind of some idea about why exercise is so important for type 2 diabetes prevention. So we believe MASI could be a potential biomarkers of exercise training. We are welcome to possible collaborations to measure MASI from various exercise interventions to determine the potential of the biomarker. Personalized medicine is a fantastic opportunity to take on a one-size-fits-all approach to diagnostic, drug therapy, and prevention and turn it into an individualized approach. Genomics plays a big role in emergence of personalized medicine because it gives us a window in a very specific molecular way into those differences between us, allows the opportunity to make individual predictions about disease risk that help someone choose as preventive plans is right for them. We can apply personalized medicine to exercise interventions. We hope our SNP story allows the possibility in some instances of picking the right types of exercise at the right dose, the right person, instead of the one-size-fits-all approaches to exercise intervention. So I hope we could see the MASI SNP being sequenced and placed in our medical record in the future.
And
Fantastic. Dr. Kim, thank you for the recording and talk. If anyone has any questions from the audience, feel free to use the question and answer setting below. And I see some people have already started to do that. Or also there's a couple in the chat as well, which I'll keep an eye out for as well. I was really interested if I can start off this question and answer session, as is my chair's right prerogative. This idea of mitochondrial encoded proteins that are influencing muscle function is really interesting. What even led you down this pathway in the first place?
Yeah, that's a really good question. I think energy metabolism, like a mitochondria is a center for regulating metabolism and energy sensing. So upon the exercise, I think the metabolic changes in circulation and even in muscle turn into the signals recognizing energy balance and metabolic needs and initiate the signaling pathways to activate mitochondria function through the nuclear involved mechanisms, as well as the mitochondria-derived peptides can secrete to the cell inside and outside and regulate downstream signaling pathways.
It's incredible how much of a role these mitochondria are playing, and we're just uncovering more and more about them. It's amazing. I have a couple of questions from the audience that I think are worth considering. Dr. Diallo Brown, apologies for getting your first name wrong there potentially, I was curious whether or not this high prevalence of type 2 fibers that's associated with chronic disease you're talking about, or is it maybe high twitch fiber predisposed people don't tend to do aerobic exercise, so they don't tend to be getting these positive effects? So are we looking at like a selection bias issue here?
Yeah, that's a really good question. So as you noticed during my talk, I have a different cohort to assess different aspects of the genetics and exercise interaction. So the cohort that we look for the type 2 diabetes is a large cohort and about like 10,000. On the other hand, the cohort we look at the composition, muscle composition, interacting with the massive SNP is only like about 100 individuals. So we actually cannot conclude whether it is a selection biases or not. But what we hypothesize here that the increased instance of type 2 diabetes by the massive SNP during aging might be related to the muscle type fast twitch muscle fiber type, because fast twitch fiber type is associated with a faster muscle atrophy during aging, or and metabolic other metabolic syndromes. But we can't rule out the possibility that the interaction between muscle composition with exercise preference that leads to the metabolic syndromes like type 2 diabetes. So in the future, I really hope that in the clinical setting or other researches that kinesiology or exercise physiologists involved in and test out whether the individuals getting this SNP or wild type have different, performance in the exercise or preference to the exercise that eventually lead to the different syndromes during aging. So we all understand that the lifestyle, like diet and exercise, are really important for us to, like to the aging and age-related disease trajectory, right? So that could be involved in the different exercise preference and lifestyles that eventually affect on the type 2 diabetes risk. But we don't know the answer yet, but that's really good point that we want to explore in the future.
And I think there's just so much scope to add this into some really interesting models. I'm going to put my hand up and apologize for missing the first 5 minutes of your talk because I had a small technical issue, but I'm here now. So I apologize if this was covered, but there's a question from an audience member, and my Teams is just clipping, my Zoom is just clipping your name, I'm sorry, but the the question is, do you think there is different effects between, say, male and female or younger and older mice, or is that not clear yet? And I think they're talking about your potentially neutralizing antibodies approach there. I'm not sure, sorry. Or if that's not the case, then if that's your question, please feel free to clarify in the chat. Sorry, that wasn't very clear for me as a chair.
So yeah, the question isn't clear. Is it about the sex and aging differences?
Yeah, I think that's the gist of it.
Okay, yeah. So in genetic data in human cohort and mouse experiment shows that the SNP increased type 2 diabetes in only Japanese male, and K14Q MASI, which produced from the individual skin carrying the MASI SNP, has a effect. So like wild type MASI only has a metabolic beneficial effect in male mice, while K14Q MASI does not have the same beneficial effect in male mice. On the other hand, in female mice, both wild type and K14Q MASI did not have any beneficial effect in our study, as other study published a couple of years ago. So we think there is a interaction between MASI and sex, and I think as I mentioned during the talk, Dr. Chu, who published the metabolic effect of MASI in ovariectomized mice, that suggests that the interaction between ovarian hormones and MASI in terms of the metabolic beneficial effect. So that's a piece of the data we have. And we actually clearly don't understand yet what is the interacting molecules in female interact with the MASI, and we are very interested in the sex differences. In terms of the aging, yes, we do see the effect of type 2 diabetes related MASI SNPs increase the risk of type 2 diabetes during aging. So in individuals over 64 years in these three cohort, it is one of the cohort shows that the increase of type 2 diabetes. So with that brings us a hypothesis the interaction between fast twitch fiber types and MASI SNP. So again, we are still understanding what drives this interaction between SNP and aging, but the human data, human core data shows that yes, this SNP increased type 2 diabetes risk in the older individuals compared to young.
That is really interesting. I think there's some really interesting scopes and directions we can take this. I'm starting to think about epidemiological approaches with, say, the UK Biobank or similar as well. But yeah. Anyway, we should probably move on. I apologize for cutting it short because we do have a time limit to keep to, and that is unfortunately my job today to govern the discussion, not just to talk to you as long as I like to, and all of our speakers today. So thank you, Dr. Kim, for your talk. And some really interesting data. Exactly what I wanted to present to an audience today was this range of possibilities from the molecular all the way up to the whole body human. I think there's some really interesting data coming up where we're crossing this over. Next up, we have Dr. Chris Kite from here in the United Kingdom, talking about exercise for the management of polycystic ovary syndrome. Dr. Kite from the University of Chester, and I will hand over to you now.
Hello, and thank you for taking the time to come in to listen to my talk. My name is Dr. Chris Kite. I'm a lecturer in applied exercise physiology at the University of Chester, actually based in my hometown of Shrewsbury, though, in the Midlands in England. You can see I'm also an honorary research fellow, namely at UHCW NHS Trust in Coventry, and also at Coventry University. And today I'm going to talk to you about some of the work that I undertook as my PhD, and also things that we've been doing as an extension to that more recently. So you can see the title of my talk is about exercise and physical activity, and exploring its effectiveness as a treatment strategy in the health and well-being of women with polycystic ovary syndrome. Just to give you a little bit of background, PCOS is often regarded as the most common endocrinopathy in reproductive age women. So we're talking usually about women aged 18 to 45 years. It affects up to 10 to 15% of that female population. Now there is a little bit of ambiguity, I guess, around what the true numbers are, and some of that variation is down to differences in regional differences in clinical practice, but also the fact that there's a use of multiple diagnostic criteria. So when we talk about diagnostic criteria, it's typically diagnosed based on the presence of at least 2 of 3 cardinal characteristics. Now those are hyperandrogenism, so women either have a clinical or biochemical presentation of hyperandrogenism, so ovulatory dysfunction, which obviously has affects reproductive outcomes, but typically presents itself as menstrual irregularity, and then of course, as the name suggests as well, polycystic ovarian morphology, so that's cysts upon the ovaries, often identified via ultrasound. Now I said that there's use of multiple diagnostic criteria, and the fact is that that those criteria have evolved over time. So in the 90s, the NIH diagnosis was used, where women had to be hyperandrogenic and present with ovulatory dysfunction, with no mention of the cysts upon the ovaries. After multiple iterations, generally the one that's now mostly accepted is the Rotterdam criteria, which, as I said, it needs to be 2 of 3 of the cardinal characteristics. Now what this means is that we end up with 4 distinct phenotypes for women with PCOS. So that is hyperandrogenism with cysts on the ovaries, hyperandrogenism with ovulatory dysfunction, all 3 of the characteristics, and the most recent criteria now mean that women don't necessarily have to be hyperandrogenic. They can have cysts on the ovaries and ovulatory dysfunction for that diagnosis to be made. And that's currently where we're at with those diagnostic criteria, that 2 of the 3, and then the type of phenotype of diagnosis should also be presented. So alongside those 3 characteristics, though, there are other things that are widely associated with a diagnosis of PCOS. Now, for starters, there's an increased risk of cardiometabolic complications. So when we think about that, we can see that there's high prevalence of overweight and obesity in these women. Often they also present with insulin resistance, so much so in fact that it has been widely debated about including insulin resistance within that diagnostic criteria. As you'd expect from cardiometabolic complications, we also see increased prevalence of type 2 diabetes, hypertension, non-alcoholic fatty liver disease, and sleep apnea too. Alongside this as well, though, women with PCOS also present with psychological morbidity. So that's increased prevalence of anxiety, depression, stress, poor self-esteem, and body image issues. And as you can imagine, the net result of this means that we often see impaired quality of life in these women, particularly when we look at that compared to women without PCOS. So as part of my PhD, we did a small case control study involving around about 130 women, and we actually compared these women with PCOS to some healthy controls, specifically looking at those quality of life measures. So we used an SF-12 to compare the mental and physical domains of quality of life, and we actually found statistically significant but also clinically relevant differences between the 2. Furthermore, when we looked at the domains just in our women with PCOS, we found that the greatest detriment upon their quality of life came from those mental health domains. Okay, let's divert our attention back to those physical symptoms at the moment. So we did another study, which was results chapter in my thesis, where we did an analysis of UK biobank cohort. So there were 320 women with PCOS in the UK biobank, and we used age and BMI match control groups, which were double in size for comparisons. However, let's focus today just on those women with PCOS. When we looked at that sample, we found that just over 3/4 of them were overweight or obese, and 50% of those women actually presented with a BMI of over 30. When we made a comparison to between those that were a healthy weight and those who were obese, we found that the women who were a healthy weight had lower fasting blood glucose and HbA1c and lower blood pressure levels. They also had improved lipid profiles, so particularly reduced triglycerides, increased HDL-C, and importantly as well, we see an elevated level of SHBG, which means that there's less bioavailability of testosterone, which should hopefully reduce the clinical manifestations of excess androgens. We see increased levels of IGF-1, and nicely as well, we see self-rated health. So those women who were healthier tend to present with favourable symptoms across a key range of important outcomes. So what we also looked at though in those women, we looked at their MET minutes. So all of the women in the UK Biobank completed an IPAC, and as you know, they're categorised based upon their self-reported physical activity levels. And we can see that in women who are a healthy weight, their MET minutes per week, so the physical activity they perform each week, was significantly higher in those when they were compared to those who are obese. And you can see that those levels are approximately double. So there appears to be some protective effect of physical activity as well. So we compared those who were the most active against those who were the least active, and we see some very similar results as well. So yes, we see some improvements in lipids, so namely reduced triglycerides in those who are active, but we also see reduced waist circumference, reduced levels of CRP, so inflammatory markers appear to be improved, IGF-1, and again we see that self-rated health is also improved. So it tends to suggest that, say, physical activity or exercise has some protective effect within these women. And given the effectiveness of exercise in other metabolic conditions, it seems to represent a potentially effective solution in the management of PCOS. And accordingly, when women are given treatment recommendations from their medical professionals, particularly those who are overweight or obese, those interventions tend to focus on lifestyle changes that promote weight loss through regular exercise and dietary control. So to put this to the test, we did a systematic review which only involved women with PCOS, but made comparisons between exercise interventions compared to usual care. So you'll see from the Prisma flow diagram for the systematic review that following our search of the databases, we uncovered around 2,400 studies which may have met our eligibility criteria. So after going through the screening process, we actually ended up with 27 records, so 27 individual papers, but only relating to 18 studies. And then from the next stage, only ended up being 17 included in the meta-analysis. It's important to say at this point that we did make multiple comparisons, so we didn't just compare exercise to a control, we compared exercise to diet, and then exercise against different combinations of diet and exercise as well. So I'm only going to talk to you about the one comparison today, and that is just exercise versus our control. And we did find statistical improvements when people completed an exercise intervention. So we found that fasting insulin was improved, so too was total cholesterol and LDL-C. We see increased VO2 max and more favourable outcomes on insulin sensitivity. Triglycerides were also reduced, so too was waist circumference and body fat percentage. So it tends to suggest that the exercise interventions do have a beneficial role in this participant group. To further explore these benefits, we also completed some sub-analyses, and we found that the greatest benefits came in interventions where participants were either overweight or obese, where exercise sessions were supervised, so whether they were organised and they were supervised by a qualified exercise instructor or a member of the research team. Also when aerobic exercise was used, and that favoured resistance training in all combined approaches that used resistance and aerobic exercise, and also where exercise interventions were of a shorter duration, typically less than 12 weeks. However, despite this beneficial effects, there are some key limitations with these findings, and the first of those is that the magnitude of the changes that were observed was typically only very small, and in fact most results, if we looked at the confidence intervals around those effect estimates, includes results that there were null or negligible findings, as well as potentially meaningful findings too. Also have to draw your attention to the quality of the additional studies. So all of the studies that were included had either an unclear or high risk of bias across multiple domains, and also there were some issues with the procedures in which the interventions have been carried out. That could be to do with the reporting, but we really did observe that there were quite small sample size used across that, which is surprising given the prevalence of PCOS across this reproductive age population of women. I think probably the average size of our intervention arms was between 10 and 12 participants, which was quite a surprising finding. We also used the grade tool to assess the quality of evidence, and all of the primary outcomes which we included, so those were primary outcomes related to metabolic syndrome, were graded as low or very low quality of evidence based upon the things that I've just outlined above. So the principal recommendation from the systematic review was that more work needs to be done in this area, and namely we need to look for the conduct of well organised and well reported randomised control trials that recruit an adequate sample size of women, and indeed that was one of the primary objectives to come out of my PhD once we got there. However, things don't always go according to plan, and at the end of the PhD process, COVID-19 hit, and it became very, very difficult to get projects such as this off of the ground. Indeed, it became apparent that many of the symptoms that women with PCOS present with, particularly those related to metabolic complications, are risk factors that have been widely stated for the development of severe COVID. So yes, we are aware that this could be one factor, but we also felt that this could lead to increased anxiety and stress within these women, which is obviously further exacerbated by their diagnosis of PCOS, and we felt that this was need for investigation. Accordingly, we managed to conduct a cross-sectional study. So we used a series of web-based questionnaires and managed to sample 333 women with PCOS. We looked specifically at the DAS-21, so depression, anxiety and stress scale, and found that there was prevalence of at least mild depression, anxiety and stress in 80, 70 and 65% of the population respectively. And when we compared that to data reported from a previous meta-analysis in the general population, so during the COVID-19, we found that those instances were at least double in all of those three elements. We also found, we asked the women about their physical activity behaviours and how they had changed, and we found that 60% of the sampled women had reported that the UK lockdown had had a negative impact on the amount of physical activity in which they performed. So given the potential beneficial effects of being physically active in this particular cohort, this statistic was of particular concern for us. So however, we did want to explore a little bit further, and we wanted to investigate if there was a protective effect of physical activity, particularly given the restrictions. So in that same cohort, we asked some additional questionnaires, and one of those was an IPAC, and we were able to actually compare those performing the least amount of physical activity to those performing the most. And again, as we found a series of beneficial differences for a range of outcomes. So again, although still quite high, we found a beneficial effect of BMI. Those performing more physical activity had a reduced BMI compared to those performing the low or moderate amounts. We also found differences in depression. So prevalence of depression and perceived depression was lower. The WEMWEBS is a mental health and well-being scale, and that was improved as well in our people who are more physically active. They were sleeping better, they rated their own health better, and they also perceived their illness, their PCOS, to have less of an impact in their day-to-day life. So despite these findings, we're aware that there's limitations with self-report data, and indeed these are widely reported elsewhere. So we felt that there was a need to get some device-measured physical activity from this cohort. So we were able to recruit a subsample of those women, 17 in fact, to wear a smartwatch during the lockdown restrictions. And we captured 14 days of physical activity amongst other data, and also asked them to complete some online questionnaires to cover the same period. When we completed correlation analyses, we looked at all outcomes and the total active minutes per day as measured by their watch. And we actually only found that there was an association with BMI. That is, the more physical activity performed each day in minutes per day, the reduced than the lower their BMI was. So we thought this was quite strange that we expected to see some favourable outcomes, some favourable values across other outcomes. So we decided to dive a little bit further, and we asked the question, was it quality versus quantity? So we ran the same analyses but focusing on the amount of time spent completing daily vigorous activity, and then we started to see some associations. So we used the PCOS qual, which is a quality of life measure, and we found that those completing more vigorous physical activity had improved mood and also a total quality of life score, and also had reduced depression and anxiety as measured by the DAS-21. Also, it's quite important to say at this point as well, when we looked at the vigorous physical activity measured by the IPAC, there was quite a strong correlation as well with the device measured VP. So just coming to the end of the talk then, I'd just like to try and draw some conclusions for you. So it appears that from the results of the systematic review and other studies, exercise interventions appear to have a beneficial health effect for women with PCOS. However, the magnitude and the true effectiveness of that is still slightly questionable. What we have seen from some of the cross-sectional studies that we've done is that women with PCOS who engage in regular physical activity, particularly where it's vigorous, tend to have more favourable health compared to those who are the least active. Now, this data does appear to be promising, but obviously there are some issues with the way in which it is being collected. It makes it very difficult to identify causal links. In fact, are these women less active because they have worse health, or do they have worse health because they are less active? And what we need to do is just carry out some well-designed randomized control trials, particularly those that can utilize device measured and objective measures of physical activity and sedentary behaviors. These should be an absolute priority for relevant future research, and indeed that's our future objectives. So I'd like to thank you all just for taking the time to listen. Just a few brief acknowledgements. So Dr. James Brown, who was my Director of Studies for my PhD, and Drs. Yanis Carew and Ian Lahart, who were co-supervisors. Professor Harpal Randiva at UHCW, and Dr. Lou Atkinson, Gordon McGregor, and Drs. Kane Clark from Coventry and Aston respectively. And finally, Verity, the UK PCOS charity, who have been so supportive of our work and helping us recruit. Thanks very much for taking the time to listen. I hope you found it interesting. All the best.
Fantastic presentation there by Dr. Chris Kite, University of Chester at the moment, but did a lot of his work with James Brown and Ian, who I'm sure many people in the audience might remember from previous conferences. This is just me talking for a few minutes to stall to see if Dr. Kite is with us. We're currently having a bit of a technical problem. We're trying to get him back, but we don't seem to have him online, unfortunately. So what I'm going to suggest is I'll put his email into the chat box. If there's any specific questions that come up in this question time, we might email Dr. Kite and ask him those. Unfortunately, I'm sorry. And just a reflective point I wanted to make as chair. One of the things I was looking for when we put together this group and the speakers today was both a range of types of people tested, not just the traditional white male of exercise physiology, but also a diversity of approaches to answering the questions. One of the things I found most impressive with both of the talks we've seen so far is how we've used multiple models to provide evidence for the same question that they're answering. And I really enjoyed that about Chris's work in particular, where we saw that very critical approach to understanding the data and then using multiple methods to try and answer it within the realms of possibility, having lived through COVID pandemic we're in at the moment. Some of the questions that have come up from the audience, one is from someone who works with PCOS patients and works with weight training and cardio, which is very much in line with the recommendations we saw coming out of that talk. But the comment was that their weight didn't substantially change because they were gaining muscle mass and losing fat mass. And so the question to Dr. Kite was one of, is it losing weight that was the primary outcome, or was it possibly losing body fat specifically? He's not here to give his opinion. If I had to guess, I would guess he would say body fat, not body weight per se as a health marker. It's always reassuring to see my fellow chairs and speakers nodding in the background when I say that. And apart from that, I don't think we have any other questions in the chat or the question box at the moment, sorry. So if there's any specific questions from anyone in the audience, I'd suggest I will get Dr. Kite's email and put it in the chat now during the next talk. And we'll move on to the next talk now. by Dr. Mahmoud Othman from Damascus University in Syria, with an incredibly important topic, speaking of not just studying one group of humans, looking at body composition and NCDS in physically disabled adults, the physically active and active comparative study. Some data that I'm really looking forward to hearing about. Dr. Othman, I'll pass it over to you.
Chairman, professors, students, ladies and gentlemen, perceiving that many international studies and reports have displayed conclusively that NCDs are responsible for more than 63% of the annual number of deaths globally, and that 80% of these deaths occur in lower and middle income countries. This challenging issue became more complicated when we consider the specific category of disabled people in general and the further specific category of the physically disabled in particular. As the WHO and World Bank specified in their report, that the rate of the development of chronic diseases and consequently the incidence of death is greater among the disabled population compared to the healthy. Moreover, the development of NCDs and the critical incidence of death in disabled population may have tripled or more in crises such as environmental catastrophes, severe conflicts, or economical emergencies. On the other hand, in relation to body composition, the incidence of overweight and obesity is distinctive and characteristic phenomenon among physically disabled people, especially among those who suffer from a lack of the ability to move adequately and or the existence of rigorous circumstances and limitation found in crisis to move freely, such as going outside or even to parks. Furthermore, physically disabled persons often choose adjusting to the requirements of their life situations and their daily functionality and complications through solutions that do not require effort and burning energy. These facts directed us to the idea of the present study, which addressed hidden victims during the course of three crises: body composition and non-communicable diseases in physically disabled male adults, active, inactive comparative study. First, three crises mean in the current study. First is the severe conflicts in Syria. Second is the associated economical emergency. And the third one is the global corona epidemic. Hence, the aim of the investigation was to explore the body composition and the prevalence of non-communicable diseases in physically disabled adults. Moreover, to compare the studied variables between active and inactive participants. About subjects and methods used in the present investigation, current study consists of 251 physically disabled males from Damascus City and its countryside with the age range between 20 and 73 years. Anthropometric measures, physical activity classification, and physical disabilities were evaluated based on the official medical reports relevant to each case. The distressed data presented in Table 1 was the value of body mass index where the majority of the physically disabled adults in the present study were belonging to the overweight category. This data may support the facts mentioned in the introduction, where disabled in general and physically disabled in particular may have the triple or more incidence of the development of non-communicable disease and or overweight and obesity. However, according to causative factors of their disability, participants were classified into four categories: bone joints disability, muscular disability, postural disability, and other disabilities which do not fall into the mentioned categories. Regarding the physical activity status, as it presented in graph 1, the percentage of physically active participants ranged between 2.56 in postural disability and 15.38 in bone and joints disabled participants. In the entire sample, the active participants have not exceeded the 12.4%. For the estimation of fat mass and fat-free mass, Dorenberg equations were used, where percent body fat was strongly related to body mass index, age, and gender. Regarding this method, Dorenberg et al. Have evidently stated that those who classified into overweight and obesity category must have more than 23.2% of body fat. Now turning into the results and discussion of the current study. As it's shown in graph 2, the percentages of inactive physically disabled adults were 87.5% for thin category, 78.9% for normal weight, and 95.3% for overweight and obese category. And for the entire sample, the percentage of inactive participants was 87.6%. Per contra, the percentage of active persons were 12.5%, 21.1%, 4.6% for thin category, normal weight and overweight and obese category respectively. And for the entire sample, the percentage of active individuals was worryingly just 12.4%. The worrying-provoking percentages of inactive physically disabled persons might be consented if we compare them with findings from previous several surveys and studies concerning healthy but not disabled individuals in some Arab countries, such as the study of Mansour et others at 2017, where the percentage of inactive healthy adults aged 30 to 70 years old in Saudi Arabia was 96%. Now, in relation to body composition of the physically disabled, Table 2 indicates that there were no significant differences in body length between the active and the inactive. But the differences were significant in weight, fat mass, and lean mass. In spite of that, we have to declare that the arithmetic averages and percentages of fat mass and lean mass classify the current sample members entirely as a unit group within the category of overweight and obesity. This result was approved in consistence with Dorenberg recommendations, where the 23.2% fat mass was the cutoff value for classifying patient as overweight and or obese. On the other hand, graph 3 epitomized the prevalence of NCDs in the whole sample according to activity classification. We can observe that diabetes came first with 10.76%, then blood pressure with 9.16%, after that cardiovascular diseases with 6.37%, then muscle and joint diseases with 4.38%, then lower back pain 3.19%. However, the deplorable percentage of persons with more than one disease have exceeded the 7.5%. In addition, there were no significant differences between active and inactive in the emergence of chronic diseases. The non-significant differences between active and inactive participants could be explained by the fact that the three crises have inhibited, or in most cases stopped, both categories to perform or achieve their rehabilitative programs or even to live their usual familiar daily life. The attention-grabbing results perceived in graph 1 was the number and consequently the percentages of physically disabled adults with at least one non-communicable disease, wherein we can make a simple calculation from table 2. If we add the numbers of patients who have at least one NCD at each category, then the results will be 85. This is equivalent to 33.86% of the participants had at least one NCD. Moreover, to differentiate active from inactive participants, also we can calculate the percentages separately as it presented in graph 3. Active were 6%, and this equivalent to 19.35% of active participants had at least one NCD. Inactive were 79, and this equivalent to 35.91% of inactive participants had at least one NCD. If we add those who have more than one NCD, then 79 plus 17 is equal to 96. The result is 96 persons, and this equivalent to 43.63% of inactive participants had at least one NCD. This may be strengthening the statement of several studies and reports, such as WHO and World Bank report, which expressed that crises elevate the incidence or development of NCDs by triple or maybe more. The next step was to explore the prevalence of NCDs in the whole sample according to body mass index classification. In order to demonstrate the negative effects of overweight and obesity, we compare the people of thin and normal weight together with those who were overweight and obese. From table 4, we can affirm that the percentage of blood pressure onset among individuals in the underweight and normal weight category was 3.51%. while in the overweight and obese category was 14.73%. The diabetes rate was 4.99% compared to 17.05%. The percentage of cardiovascular diseases was 1.75% compared to 10.85%, and the percentage of muscle and joint diseases was 1.64% compared to 6.98%, and the percentage of lower back pain 1.64% compared to 4.65%, and all the differences were statistically significant at 5% for all variables. Among the points of interest in graph 3 is that the number of overweight and obese participants, which was 129%, yet it was greater than the number of individuals in the underweight and normal category combined, which was 114%. This result can be traced back to the well-documented fact, which indicates that the physically disabled are 3.9 times more likely to be overweight and obese than normal individuals. Nonetheless, the presence of more than one disease was 2.46% in the category of thin and normal weight, while in the category of overweight and obesity, the percentage was 12.40% with significant differences. These data and their statistical treatments confirm the well-documented strong relationship between body composition and the development of chronic diseases among the physically disabled. And finally, to make the relationship between aging process and the NCDs clear, We can note from graph 4 that the emergence of chronic diseases is in an ascending sequence with age for the physically disabled, as it was clearly shown that exceeding the age group of 19-30 years is the time limit in which these diseases begin to appear frequently. Blood pressure migrated from 0 in the age group 19-30 to 34.37% in the age group over 60. Diabetes from 1.69% to 34.37%. Cardiovascular diseases from 0% to 21.87%. Muscle and joint disease from 0 to 18.75%, and lower back pain from 0% to 15.62%. Additionally, in the case of the presence of more than one chronic disease, the percentage moved from 1.69% in the age group 19-30 years to 28.12% in the age group over 60 years. Ladies and gentlemen, the results of the current study related to the increasing trend of chronic disease with age are similar to those in previous studies and reports, with awareness that the immobility of the disabled adheres to an inactive and dependent lifestyle. Additionally, taking appropriate preventive and curative precautions is one of the primary causes of the development of chronic disease and the symptoms resulting from it, or even for the emergence of another disease associated with it. Dear concerned colleagues, as a suggestion included from the related literature, we can clearly declare that aging process itself might be responsible for the development of chronic non-communicable diseases in healthy and in disabled population similarly, but unfortunately with higher incidence rate in the disabled population. Beside the traditional modules and protocols, this process can be delayed or prevented, treated by a regular physical activity, even home-made physical activity, but for scientifically accepted and evidenced positive results, a proper formulated regular exercise programs are needed. I wish to meet you all in person, wishing you, all of us a successful conference, and thank you for your kindness attention.
Fantastic talk and some interesting data there by Dr. Mahmoud Othman, who, with an incredibly bad luck piece of timing, having been with us the entire session so far today, has in the last few minutes lost his connection to the internet. But if we get him back, that'll be brilliant over the next few minutes. And if not, we'll do the best we can. But I'd remind anyone that has any questions, we can just type them into the question and answer box or into the chat. And if he does get back to us, we'll be able to answer them online there. Oh, I thought we might have had him for a second there, but we had the video come on and cut off again. And it was also really great to see not just categorizing some difficult data there, but also the suggestion of solutions towards the end there. We saw the exact same thing we've seen in other talks throughout this conference. We see the escalation of occurrence of disabilities, of diseases, of non-communicable diseases with age. We saw exercise interventions having positive benefits. We saw everything else we've seen so far. It's been really good to see. Keeping an eye on my chat in case the technical support comes up with anything. Nothing so far. Dr. Lee, you're with us. Is there any positive comments you'd like to drop in as we just stall for a few minutes? I see him saying no desperately. No worries. Okay. Well, next up on our schedule today
is the abstracts presentations. So we have a group of abstracts from researchers that have been submitted, for which I'll pass over to Associate Professor Lim, who's going to introduce and take over chairing for the session. Professor Lim, I think the table is yours.
Thank you, Dr. Reddy. Thank you so much, and then thank you for the. All right. First of all, I would like to say thank you for those participants stay on. This is the 5th day or the final day of this 5th World Conference on Exercise Medicines, and also stay until the end of this final session. I think this is wonderful. So I'm going to take over Professor Dr. Bradley's session to chair this another 3 more abstract presentation. Yeah, because I think Professor Dr. Bradley is actually busy with his work and he can't leave, and then he have to go. I have to take over. No problem. All right. First. Okay, just a minute, and it's okay. Because I think they are sending all the information to me, so that let me to introduce. So this evening we have before the closing we have another 3 more abstract presenter. First presenter will be talking about cooperation between the transverse abdominis and muscles and endurance and also body mass index among college students. That one we have to wait for a short while so that I can introduce the, maybe the participants and also the speakers and all that. Yeah. So I think throughout this conference, I think everybody have been learned a lot throughout all this, because I think the organizer have been trying their best to get the best speaker out of every areas and all that, to disseminate their sharing and all that, the information to everyone here. I think whoever participate in this conference will be, what I can say, that is actually beneficial. And just now you just listen to another 3 more speakers and all that. They have been sharing quite a number in depth in terms of that. All right. Okay, now I can. Now the first abstract presenter in this session is actually Miss Gayatri H. Patel from India. Okay, with the title of presentation is actually correlation between transverse abdominis muscles, endurance, and also body mass index among college students. So without further ado, we just listen to her presentation. Miss, please, Gayatri, yeah, please.
Myself, Gayatri Patel, BITS Institute of Physiotherapy, Vadodara, Gujarat, India. The study title is Correlation between Transverse Abdominis Muscle Endurance and Body Mass Index among College Students, a pilot study. Introduction. Obesity is defined as abnormal or excessive fat accumulation that present a risk to health. The epidemic of obesity has become a serious problem in modern society, especially in developed countries. There are some indicators for degrees of obesity. For example, body mass index as a common indicator was used to evaluate the whole status of person's body weight. Endurance, a measure of fitness, is ability to work for a prolonged period of time and ability to resist fatigue. Muscle endurance is defined as ability to perform repeated contraction over a period of time for isolated group of muscles. In fact, most of our daily activity requires some muscle endurance. Low back pain occurs as a result of trunk muscle with the poor endurance in lumbar spine, which induce strain on passive structures. From among the core muscles, local and global, transverse abdominis muscle is controlled independently of other trunk muscles. Transverse abdominis is a deep muscle which have a segmental attachment in the lumbar spine and able to provide segmental control. Studies have shown that deep fibers of multifida and transverse abdominis are first muscles to become active when there is a postural disturbance from rapid extremity movements. it creating a belt around abdomen. Abdominal drawing of the abdomen creates isolated activations of transverse abdominis. Lower endurance of inner core muscle is one of the risk factors for mechanical low back pain. Study says that a high BMI is a risk factor for low back pain. Aim of this study to determine the correlation between transverse abdominis muscle endurance and BMI among college students. Proposed hypothesis: it was hypothesized that there could be a correlation between transverse abdominis muscle and BMI. Materials and methods: study design, non-experimental, study type, observational, sampling method, convenient sampling, sample size 30, study setting, BITS Institute of Physiotherapy, Vadodara. Inclusion criteria: age 18 to 25, male and female. Exclusion criteria: low back pain, neurological disorder, cardiorespiratory disorder, and mental instability. Materials used: plinth, sphygmomanometer, stopwatch, weight machine, stadiometer, pen and paper. Procedure: informed consent was obtained from the students and students were selected based upon the inclusion and exclusion criteria. Body mass index has been calculated for all the students. Body mass index is calculated by formula: weight in kilogram and height in centimeter square. To measure the transverse abdominis endurance, prone test is used. In prone test, the subject was lied in prone position and the sphygmomanometer pressure cuff is placed horizontally under the abdomen within the navel at the center. The pressure was infused up to the 70 mm Hg and subject was asked to perform the abdominal drawing technique and maintain the relaxed breathing. If done properly by the subject, the pressure will be reduced to 6 to 10 mm Hg. Then ask the subject to hold for the 10 seconds. 20-second break was given between the each contraction and number of 10-second hold will be considered as the transverse abdominis muscle endurance. Result: the result was analyzed using the SPSS software 16. The statistical tool used was Pearson correlation. The table 1 shows the demographic data of the students, age in the years, mean plus or minus SD. For the age to 21.23 plus or minus 2.47, height in centimeter 161.57 plus or minus 8.11, weight in kg 58.98 plus or minus 12.42. The graph 1 shows the BMI of college students. For the mean BMI of the underweight students is 17.30, mean BMI of overweight student is 26.97, mean BMI of the obese student is 31.25 and mean BMI of the normal student is 21.29. The graph 2 shows the Pearson correlation between the transverse abdominis muscle endurance and BMI, and the graphs indicate that there is a negative correlation between the transverse abdominis endurance and BMI. Discussion: the study aimed to find out correlation between the transverse abdominis muscle endurance and body mass index among college students. We found out that there is a negative correlation between the transverse abdominis muscle endurance and body mass index. Adipose tissue get deposit in the abdominal region of the obese individual that increase the waist circumference. Studies reveal that large waist circumference is associated with poor muscle function and increase the risk of sarcopenia. Transverse abdominis muscles is recognized in the literature as playing a vital and protective role in maintaining a healthy core and aiding the lumbar biomechanics in the dampening of external forces applied to the lumbar spine. Strength, coordination, and timing of the transverse abdominis muscle contraction may be important in stabilizing the low back, and contraction of this particular muscle may be one of the factors capable of preventing and reducing the low back in sports and activities of daily living. Research has shown the occurrence and reoccurrence of low back pain to be associated with dysfunction of the deep abdominal muscles, mainly transverse abdominis. The role of transverse abdominis has been demonstrated to be a great importance in continuous stabilization during movement. One study concluded that according to the body mass index, muscle strength of the quadriceps, triceps, and abdominal muscles are more in obese children when compared to the underweight and the normal weight individuals. But in case of the muscle endurance was relatively very low in obese children when compared to the other weight group children. One study concluded that abdominal muscles and the quadricep muscle strength and power were compared to body mass index have relatively reduced in obese subjects than the lower weight subjects. Our study has says that there is a significant correlation between the transverse abdominis muscle endurance and body mass index. Conclusion: there is a significant negative correlation between transverse abdominis endurance and body mass index. So the study concluded that the students with the higher BMI have low transverse abdominis endurance. Limitations: larger populations can be taken. Gender may influence the outcome. Clinical implications: there is a greater need for stabilization exercise for the obese college students. These are the references.
Thank you very much, Ms. Gayatri, for your presentation. I would like to open the floor for any question and answer. So are you ready to answer question? I'm still waiting. Well done. Good job. There's no question yet. All right, maybe I just pose one question since you are waiting here. Ms.
Yes, sir.
May I know what is the R value for your correlation since it's negative significant?
Minus 0.45.
0.5.
Minus 0.45.
Okay, minus. Sorry. Okay. Okay. Since there's no question, I would like to, on behalf of the organizer, I would like to say thank you very much for your time and for you now. Maybe you stay on until the closing. Yeah. Thank you.
Thank you. Thank you. Bye.
All right, now we move on to the next speaker. The next speaker is Professor Anna Tarij from India as well. So would the title of effect of metric rhythm therapy on the addition to brace protocol on the pain balance and also vibration perceptions on the diabetes peripheral neuropathy. So Prof, the floor is yours.
Effect of matrix rhythm therapy in addition brace protocol on pain, balance and vibration perception on diabetic peripheral neuropathy, a pilot study. I am Professor K. Anandraj, PhD scholar, Madhav University, Professor JKK MMRF College of Physiotherapy. Introduction. Diabetic person represents spectrum of metabolic disorders which has become a major health challenge worldwide. India have shown the prevalence of type 2 diabetes increase from 8.2% in 1992 to 18.6% in 2008 for urban areas and from 2.4% in 1992 to 9.2% in 2008 in rural areas. India currently has 16.1.3 million diabetics, figure that project increase 103 million by 2030. Diabetes pandemic both developed and developing countries by the year of 2030. Over 85% of world diabetic patients will be developing countries. American Diabetic Association defined diabetes mellitus as a group of metabolic disease characterized by hypoglycemic result from defect in insulin secretion. Insulin action are both the chronic hyperglycemia of diabetes is associated with dysfunction of various organs, especially eye, kidney, nerves, heart and blood vessels. Diabetic peripheral neuropathy is a complication of diabetes that result in damaged nervous system. It is progressive disease and symptoms get worse over time. Long-term diabetes with high level of fat can damage the nerve. Matrix rhythm therapy is a special therapeutic device utilizes vibration in the frequency of 8 to 12 Hz alpha rhythm to relieve painful hardening the muscle, make connective tissue more elastic and more permeable. This improves the supply of cell with energy and nutrition, thereby restore the effectiveness of body healing process. The BRACE protocol: balance, resistance, aerobic and cognitive exercise. The protocol hold recent years. The group exercise for safe and have potential to improve the balance and reduce the pain. They should be used very useful for supportive therapy for diabetic peripheral neuropathy patients. An exercise based on BRACE protocol is given the patient with the peripheral neuropathy to improve the muscle strength. The matrism therapy delivers physiological rhythmic oscillation between 8 to 12 Hz, synchronize the internal body rhythm, restore the effectiveness of body healing process. Aim of the study: to identify the effect of matrism therapy in addition BRACE protocol on pain, balance, vibration and perception on diabetic peripheral neuropathy. Object of the study: to identify the effect of matrism therapy and BRACE protocol on pain, balance, vibration, perception on diabetic peripheral neuropathy. To identify the effect of BRACE protocol on aerobic exercise on pain, balance, vibration, perception on diabetic peripheral neuropathy. To associate the finding of the study with demographic data. Methodology: study design, quasi-experimental study. Study setting: Supreme Bharat Hospital, Kumarapalayam, Gurunath Hospital, Kumarapalayam, Anbe Shivam Diabetic Hospital, Bhavani, JKKM Trust Hospital, Department of Physiotherapy. Selection of sample: a sample random, simple random sampling method. Study sample: the total number 20 patients was selected. Group A 10 patients, Group B 10 patients. Under the inclusion criteria: study duration 10 weeks. Inclusion criteria: the patient diagnosed with the diabetes peripheral neuropathy according to clinical EMG data. Age group 40 to 65, both gender, more than 10 years, uncontrolled type 2 diabetes mellitus. Exclusion criteria: severe cardiovascular and respiratory disease, CVA patients, unhealed diabetic foot ulcer, Hansen disease, Parkinson disease, vertebral artery insufficiency. Procedure: Group A receiving BRACE protocol. The BRACE protocol 3 days a week for 10 consecutive weeks alternative days. The exercise includes static balance exercise plus chair raise 30 seconds without using hand, push the wall, static and dynamic anticipatory postural control plus stair climbing without using rails, marching in space, remember 5 words, name of 5 animals, repeat the 5 words. Procedure: static, dynamic, anticipatory postural control plus squatting, cycling, count even numbers 1 to 50, calculation, addition, subtraction, multiplication, divisions or combinations. The therapy for preservative enhancement of restore the movement, physical function, improve the treatment the disease, injuries or disability, utilize the therapeutic exercise physical modalities. Assisted device: the patient education training, home programs, peripheral neuropathy exercise, enter range of joint motions and exercise followed by without or with weight bearing, warm up exercise, cool down phases. Methodology: Group A receiving matrism therapy and BRACE protocol. Group B receiving BRACE protocol and aerobic exercise. Number of participation 10. Intervention: Group A receiving matrism therapy 30 minutes, BRACE protocol 30 minutes. Group B BRACE protocol for 30 minutes with aerobic exercise 30 minutes. Methodology: outcome variables, pain, how does brief pain inventory, short form of diabetic peripheral neuropathy, balance, postal sway meter. Results calculated using the paired t-test, unpaired t-test, the results showing collection with statistical significance 0.05. The table comes showing Group A and Group B. Mean difference 1.5, unpaired t-value is 3.21. Postal sway for balance, Group A and Group B, standard deviation 0.8, unpaired t-value 4.8. So discussion: matrism therapy delivered physiological rhythmic oscillation between 8 to 12 Hz, synchronized with internal body rhythm, improve microcirculation, improve the oxygen supply, ATP production, repolarization, relaxation of the tissues. The BRACE protocol: balance, resistance, aerobic and cognitive function, Protocol hold recent years balance excessive flexible for safe and potentially improve the balance. Conclusion. Group A, the significant improvement noted following matrixm therapy along with the brace protocol in diabetic peripheral neuropathy than the brace protocol in European exercise. Acknowledgement. All the diabetic peripheral neuropathy patients, management of JKK MMR of College of Physiotherapy, Namakkal, Tamil Nadu, and my guide Dr. Anand, Professor Madhav University, and my co-guide Arnachalam Sir, Madhav University, Rajasthan. These are all my reference. Thank you.
Thank you, Professor Anataraj from India for your wonderful presentation on this, the new methods in terms of the therapy to adding into the brace protocol and all that. Yeah. So I would like to open the floor for any question.
Sir, very good afternoon, sir.
Yeah, good afternoon. Yes. All right. So far, there's no question yet. Never mind. I just simply pose you a question and all that, so that maybe not so boring. You know, you waited for so long and all that. So when you presented, you talk about from 1994 to 2008 that the Indians, the number of people getting diabetes is so high. So can you share with us what is the main cause, like Indian, so many people got diabetes?
Especially South Indian peoples are more easy to eat for rice, sir. That rice impact on carbohydrates, sir.
Oh, due to rice. We Malaysian also eat our rice. Not because of sugar.
That carbohydrate, blood glucose level, sir. The carbohydrate directly relevant for blood glucose level.
I see. But that's why I can see that you actually collected the statistic is actually from so many hospital and all that easy for you because the number is big. Yeah. All right. Maybe I got one or two questions for you. What is the nerve regeneration rate in the neuropathy patient? Professor, can you hear me? What is the nerve regeneration rate in the neuropathy patient? We lost you? Professor, can you hear me? Since we lost the connection with the professor, maybe this question will post it to the email to the professor so that he can answer. Another question, I think Dr. Aswani asked also, can we cure diabetes with the exercise and yoga? I think you want to cure is a bit difficult. I think maybe this one the professor can answer to you in the email, because I published a book also in this exercise and on the diabetes type 2, right? So it's okay. So if no further question, I think the organizer will send the question to the professor so that the person who asked can get the answer from there. All right. With that, I think I would like to, on behalf of the organizing committee, I would like to say thank you very much for Professor for your time that sharing your research study and all that. With that, we are going to move on to the next speaker. Next speaker is actually Mr. Intia Ali Meng. Wow, this is something very, very different. Malaysia. And his topic is actually effectiveness of spring interval training on the anthropometric measures among obese and also overweight young adults. This is very interesting topic. So that without further ado, I would like to invite Mr. Imtia to present his topic. Please.
First of all, me and my colleagues would like to thank the organizing committee of World Conference on Exercise Medicine for giving us opportunity to present our work in this prestigious conference. The systematic review we carried out was the efficacy of sprint interval training on anthropometric measures among obese and overweight adults. WHO data shows that 1.9 million adults aged 18 and above in year 2016 were having a BMI of more than 25, which is classified as overweight, and 650 million out of these 1.9 million had a BMI of more than 30, which is classified as obese. So both obesity and overweight can increase the risk of cardiovascular disease and metabolic syndrome, which can reduce the quality of life drastically. The increase in this obesity and overweight over the years is contributed due to the unhealthy lifestyle that we live, urbanization, stress, lack of time to do exercises. American College of Sports Medicine and WHO recommends an individual should engage in 150 minutes of moderate intensity exercise per week, or at least 75 minutes of vigorous exercise 3 times per week. But we know that lack of exercise in these modern times is one of the main reasons that causes the barrier to engage in physical activity. So we have to find an alternative approach which is more term efficient and at the same time can help in increase these anthropometric variables in these individuals who are living an unhealthy lifestyle and leading to the obesity and overweight. To overcome the time constraint, sprint interval training can be utilized, which uses supramaximal effort at an intensity of 100% of maximal oxygen uptake. This sit has many variations, the vintage being the traditional approach in which a sprint of more than 30 seconds is used, and the modified sprint protocols, which are most commonly used, have a sprint of less than 30 seconds. There are concerns raised by various researchers about the strenuous nature of the sit protocol, but due to its variability, it can be very effective and enjoyable. There was a need to carry out this study as there is no specific review being carried out on the efficacy of sit on the body composition. In addition to that, there is no specific review being done on the effect of different types of sit training protocols on the anthropometric measures. So the objective of this study was to investigate the efficacy of sit on the anthropometric measure among overweight and young adults. We use pico variables for our search strategy. The population being obese and overweight adults aged 18 to 40 years old, intervention, the sit protocol, comparison using a control group with no exercises, and outcome measures related to the body composition such as body mass index, body fat percentage, and subtotal fat mass. We searched 6 electronic databases to look for the eligible studies, and to avoid the publication bias, at least 2 databases were involved for the systematic review. The key words that were created for this study were the sprint interval training, sprint interval exercise, and interval exercise for intervention, and other for outcome measures and population, that being the anthropometric measurements, body composition, overweight and obesity. The cluster of these terms were combined with and the terms within the cluster were combined with are. The table here shows the 6 electronic databases and the key terms that were used for the search of the articles. The inclusion criteria for this study was overweight and obese adults aged 18 to 40 years engaging in sit training protocol for at least 2 weeks or more, with the outcome measures related to the body composition which were measured at the baseline and at the post-intervention. The exclusion criteria was the studies not published in English, duplicates, non-randomized control trials, studies not involving human, and also the studies that have involved the participants with other comorbidities except the metabolic syndrome, and studies that were not published between year 2009 to 2018. At the beginning, screening of titles and abstracts were carried out, which was followed by the full screening of the previously included articles, which was done at the first stage, and at both the stages screening was done by 2 independent reviewers. In case if there was a disagreement between the first 2 reviewers, a third author was involved, and based on the mutual understanding of all the 3 authors, a final decision was made. And the finding of this study was based on the PRISMA statement. The PRISMA flowchart here shows how the articles were identified, screened, and finally included in this study. Initially, 1,278 articles were identified, and after removing the duplicates and looking at the exclusion criteria, finally only 5 studies were included in this systematic review. The appraisal of 5 selected studies were carried out using the TESTIC scale. This TESTIC scale has more better reliability and validity than the Pedro scale and gives a clear idea of how each study has performed at each stage. After extracting the data from all the 5 studies, we found that the total sample size in these 5 studies were 170, 99 being women and 71 being men, and they had an age between 18 to 39 years old with a BMI of ranging from more than 25 and the unspecified upper age in the obese category. The training mode in the SIT protocol was usually the cycling mode used, and out of the 5 studies that were included in this final review, only 2 studies showed the significant difference between the baseline and post-intervention. And looking at the overall quality of each study, based on the TESTIC score, which gives a score of 15, the score for these 5 studies range from 8 to 13, 8 being the fair and 13 being very, very good quality of the study. The first study was carried out by Jobur et al. In 2015, and this study showed no significant difference between the groups from the baseline and post-intervention, and the TESTIC score achieved by this study was 9 out of 15, which is comparatively acceptable. The second study was also carried by Jobur et al. In 2017, and in this study also we do not see any significant difference between the baseline measurements and post-intervention, and the study achieved a score of 8 out of 15, comparatively lower score than the first one. The third study included in this review was carried by the Gupe et al. In 2015. This study showed a significant difference between the experimental and control group in terms of subtotal fat mass, upper limb fat mass, lower limb fat mass, and the quality of the study was acceptable with a TESTIC score of 9 out of 15. The fourth study, which was included in this review, was carried by the Franca et al. In 2018, and this study also did not show any significant difference between the groups from the baseline to the post-intervention, but the overall quality of the study was very good with a TESTIC score of 12 out of 15. And the final study was carried by Tong et al. In 2018. This study also showed a significant difference between the SIT training protocol and the control group using the body mass, total body fat percentage, whole body fat percentage, guanoid fat mass, trunk fat mass, and other variables. And if you look at the overall quality of the study, it was very, very good, 13 out of 15 in the TESTIC score. 2 of the 5 studies showed the significant effect between the baseline and post-intervention, and there is some agreement and disagreement between authors that SIT training protocol can be an effective protocol, whereas some disagree it is not that effective. So as you can see from the reference given in this slide, authors disagree and some agree, and the final take from this is that training dose and intervention duration of the SIT training protocol can play an important role to be very effective in reducing the anthropometric measures as well as the body composition in these young adults. SIT training utilizes the glycolytic pathways as well as increases the catecholamine production and growth hormones, and all these factors help in increase fat metabolism and fat uptake. At the same time, if we look at the individuals who engage in this exercise, post-exercise oxygen consumption is higher in SIT, explaining that the strenuous nature of these exercises helps further increase in the muscle metabolism even hours after the training, producing higher rate of the free fat uptake. It is thought that modified SIT protocols have similar or even better benefits than the traditional vintage protocol, and some more, these modified sprint protocols can be used for those patients who are deconditioned, who cannot sustain activity for a very, very long period of time. Thus, these SIT protocols can be individualized due to its variability and still can produce very effective responses. Studies carried by the Viana et al. And Tong et al. Shows that SIT is more time efficient with similar outcomes on the body composition, but supervision is needed for the beginners. In conclusion, we can say that SIT is very effective in reducing the body composition, and it can be individualized to the person's needs, but more robust trial designs with long-term follow-up are very important to ascertain the full potential of the SIT training protocol. These are the references for your further reading. Thank you very much.
Thank you, Mr. Imetia, for your presentation. I think, yeah, I open the floor for the question. There's a question for you. Kindly discuss the preventions of shin pain in obese after running. Can you hear the question? The shin pain after running.
Okay, all right. So usually the shin pain which can be seen in these obese patients, of course, they have to start with the appropriate warm-up protocol, okay, before they begin the running exercise, whatever kind of running they are doing. They must ensure that they carry out appropriate warm-up exercises to avoid any injury to the lower limb and to the shin, which can aggravate the pain. So appropriate warm-up can be in the form of stretching, okay, can be in the form of spot marching, can be in the form of going for a jog first before person starts to run, okay. And this warm-up should be carried at least for 10 to 15 minutes before going for the vigorous exercises like running or the protocol which I have mentioned in my study, the sprint interval training protocol.
Cool. I don't see any other question. Maybe I got a question to clarify that. Number one is, since you are talking about obese and overweight young adult, is it safe to use SIT for them?
The research, from the research point of view, it has been shown to be very safe, because it is not that you are continuously using the sprint interval training. You are using just less than 30 seconds of sprint, which can use the 100% of oxygen uptake, and you are giving 3 to 4 minutes of passive recovery, where person needs to only jog or walk at a comfortable own pace. Okay, and again after the four minutes of recovery period, they have to do this again only for less than 30 seconds. So this usually has been shown to not impose any serious risk factors in terms of causing injury, and at the same time to be on the safer side and to prevent any further injury for these obese and overweight individuals, maybe we can introduce the familiarization training protocol before they actually engage in this more vigorous type of exercises. So this familiarization exercise protocol can be carried out for 1 to 2 weeks, where the intensity of exercise can be only maybe 60 to 70% of their maximum heart rate. Once they get used to the exercise for 2 weeks, after 2 weeks of training, then only they can go for this strenuous kind of physical exercises.
Okay, with that, thank you for your answer. All right, there's no other question. Then on behalf of the organizing committee, I would like to say thank you very much for your presentation.
I think there is one more question. I can see how many types SIT protocol given. So I don't understand what exactly this question is asking. How many types SIT protocol is given? Is it talking about how many sessions of exercises to be given? Is it asking about what are the different variations of the SIT protocol? I don't understand this question. So to answer this, I will answer the both questions. If the participant is asking how many protocols are available in the SIT, there are so many variations. Okay, some of the SIT protocols can be only for 6 seconds, where the sprint lasts for only 6 seconds. Some use 10 seconds sprint session. Some use 30 seconds. Some use 20. So there are different variations. There is no hard and fast rule with respect to how many different variations can be used. But the sessions, how many sessions person should carry out, again, it varies from the researcher to researcher. Some carry the training for 6 weeks, 3 sessions per week. Some carry it for only 4 weeks, 3 sessions per week. So at least if we are looking at reducing the anthropogenic measures, particularly the body composition, the fat and adipose tissue in overweight and obese adults, we should at least encourage the participants to go for 3 weeks of training per week, a minimum of 6 weeks training. Okay, more the better. Maximum they engage in 6 to 12 weeks, it is better definitely, but at least 6 weeks should be appropriate for the weight reduction.
Okay, thank you for your answer once again. On behalf of the organizing committee, I would like to say thank you very much for your presentation and sharing very much all that. So with that, I think again, I think we have been come to the end for this symposium. I would like to say to the organizing committee that thank you very much for all the participants who stay until today, final day, and also stay until the final session of this conference. With that, I will hand over the session to the organizing committee. Thank you very much. Thank you.
Thank you, Dr. Lim.
Thank
you for chairing the session. And thank you to all the speakers and also the abstract presenters. I will be posting our chairman, Dr. Jessie Lai's closing speech into the chat box, because unfortunately she is unable to be with us for the closing, as after the company's inaugural 7th anniversary celebration 2 days ago, she has a lot of things to sort out. And I will be doing the closing with every one of you here. All right. First and foremost, I would like to say thank you to the scientific committee for your dedication and your time that you have actually sacrificed, I would say, to get the program up and going for the 5th time, right? And for the abstract presenters, for the researchers, thank you for your participation to this. And for other speakers that we have actually invited, thank you also on behalf of the organizing committee. And also I'd like to thank the technical team who has been with us 2 days prior to the conference, and also the working committee, right? Especially Misha, Adli, Ethan, Chi, Rin, Nora, and Rajesh. So all these are students of mine. They are exercise therapists now. They've been working non-stop. All right. And as we all know, the exercise medicine conference has been going on for every 300 days. And we are actually moving on to more and more discipline and focus on to more and more discipline. This year, we are looking into the geriatric, which is the elderly program. And while we are doing that, and then it came on to the issue of this pandemic with the COVID-19, and we are working on that too. I just spoken to Dr. Domenico, right? I have also spoken to Dr. Hansen Huang. Is Dr. Hansen here, right? Okay. Hungary, I have not spoken to them yet, because I know they are very busy with the new campus. We would like to, in fact, the chairman also has agreed that we would like to have another country to carry out this conference, to make the entire program a little bit more refreshing, right? So, in fact, Doctor from Taiwan and Italy, they are, and also, if I'm not wrong, yes, from Finland, right? I don't know, but because of the MCO, I think we have all got our schedule all jumbled up. We all have got our all our planning all haywire, and we really have no direction at all. Whether we are able to meet live next year, either it's in Finland or Taiwan or even in Italy, we are not sure because of the situation now, all right? But I do hope and pray that the situation will be better, right? No more people dying from the COVID-19 infection, and we are able to meet each other, and we'll see how it goes. So this is how the situation is, right? I actually would like also, for the closing this time, I would also like to have say a few words. I think this is one of the things that Dr. Lai has actually wanted to say, her personal thank you, right, to all of you all. You can also read her message there, but I just pull this one out. A personal thank you to everyone who have shared your knowledge, all right? And she has put a quote that gaining knowledge is the first step to wisdom. Sharing it is the first step to humanity, right? I think humanity is the right word now. The fact that we are all aware and we all know the science behind exercise now. is indeed very effective, is indeed very distinctive, is indeed very, very important as a form of a lifestyle for people to improve the immune system, to get better health. Okay, so from there, I think I would like to, on behalf of the chairman, we would like to close this scientific program for the 5th time in Malaysia, and we hope that I would like to have the 3 person. I do not know whether Hanson Huang is here and Hannah Wemas is here. Domenico, I can see you. So if these 3 persons are here, I would like you all to say a few words if and so that you are possible to host this program. You want to say a few words, and we'll start from you, Domenico.
Okay, I'll go first. First of all, thanks and congrats. I've been writing several times on the different chats. This has been an excellent event. They always been nice, but they get better and better over the years. We've been shortly talking with Dr. Lee about the possibility of hosting somewhere else. I find this very interesting because apart from refreshing, it will give the opportunity for other areas of the planet to get in touch with this initiative much better. So we can think of a larger European involvement being here. And given the strength of our Asian friends, this could be a great venture. The program could be slightly changed. I like the fact that all the aspects of exercise regarding to medicine as disease, cancer, cardiovascular, and so on, and lifestyle prevention of these diseases are outlined. One possible option is to involve the presence of the relevant scientific society, cancer, diabetes, cardiovascular, the European level, to make something which is world, not only because we have 32, 34 countries, but we have a great scientific support to make this the event of exercise medicine.
Great, thank you. Thank you, Dr. Domenico. All right, unfortunately, Finland is not here, Taiwan is not here. Or is there any other country who wish to host the conference next year? What about Philippines?
We'll be very glad to go to Philippines.
Yes.
Or Taiwan.
Prof. Henry.
Yeah, I think it would be very nice for Philippines to host. However, we will try to check the possibility of having the situation controlled, the pandemic, and it will be a great opportunity for the Filipinos to offer you our grand hospitality and share the best practices of exercise medicine coming from the different countries. And let's see, I'll try to talk to the Philippine Sports Commission if they are able to consider supporting the hosting of this great conference.
Thank you, Prof. Henry.
Yeah.
What about Mahmoud? How are you, Mahmoud, my friend? Your microphone.
You're on mute, Dr. Rahman.
You know there's a microphone on there? Click on it, please. I love saying that. Okay, it's all right. I think there must be some connection with them. All right, you see, for delegates and all the participants here. Yes, Mahmoud.
Yeah, that's good. That's good. Now, I think the problem is getting better. Now, I hope this conference will be in another place than Malaysia. But I think Italy, Philippines, and maybe in Syria sometimes, I will be appreciated for that to to say welcome for everybody in Syria nowadays. But I think we should wait a little bit of time because, the crisis in my country is still on. I think, and I wish deep to meet all of you in person in somewhere, sometime out of the pandemic of Corona. And thank you so much for this informative, truly real information about exercise and its effects on NCDs. Thank you, Dr. Lee, for your invitation. Thank you, Dr. Domenico and Dr. Bradley, for hosting me as a speaker. Thank you so much.
Thank you. Thank you, my friend. Dr. Rehan, are you around here? Can I see your face, Dr. Rehan?
Hi, yes.
Oh, okay, you are here. Dr. Rehan, thank you very much for being very helpful here. We have a couple of. What about Hungary? Is Hungary going to be settled down more onto their new campus and looking into the possibility of hosting the conference?
Yeah, actually, they're working right now.
Pakistan? Are you in Pakistan?
I'm in Hungary right now.
Oh, okay.
Yeah, I'm in Hungary. I was in Pakistan in last August, and now I don't know when I will be there.
Okay.
But probably in Hungary, they're working right now in the new campus. They're working right now. Actually, they have launched the new clinic. It's going very well. There are a few more projects in Hungary. We are working on it. I would wish that the conference will held in Hungary as well. I will try to discuss with Dr. Berkesh and Dr. Zsombor, and we can host it definitely with your support, of course.
Good. Thank you. Thank you.
Thank you very much.
Sure. Thank you. Now, as all the delegates here, as you know, that this scientific program, it's a very friendly program. It comprises of all medical professionals, medical specialists, exercise scientists, researchers, lecturers, professors. This is a program that we share knowledge. Right? This is a program that we share to the world as much as we can in a topic that is so simple called exercise. Right? And the fact that it is so simple that everyone should know how to do it, but yet there are more people dying every year. Right, so I think, of course, there are more to that, but exercise being one of the four most important killer in NCD. All right. So as now, I would like to hear from Dr. Domenico and Henry, Rehan, the possibilities of your country hosting it. Once again, thank you very much to all. You will receive our chairman's closing speech in the chat box, and we will meet again in the next 300 days. And I will be calling for a short scientific committee meeting, and from there we will proceed on to the next conference. All right. Thank you. Stay safe, stay healthy, and bye-bye.
up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. Here is where we stand. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Oh, let your steps pick the way for the future. 'Cause you're alive, inspiring others. Don't you lose your hopes due to hurt and loneliness. 'Cause there's always another way. And all the nation together as one, fighting for a brighter future. Gathering all our brothers in arms, here we will stand tall. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Just keep moving. Just keep moving. Just keep moving. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is yours now, so just keep moving. Oh, yeah. Pick up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. Here we up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. Here is where we stand. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Oh, let your steps pick the